A hearty welcome to this webinar. This evening, I am sure all of you are going to have one of the most wonderful webinars you have ever attended. Dr. M.S. Ravindra, who is a senior most ophthalmologist and a very renowned surgeon of India and the managing director of Karthik Netralaya. He was also the ex-president of Karnataka Ophthalmic Society and Bangalore Ophthalmic Society. He, along with his daughter Deepthi, have put in this webinar wherein they have called none other than Dr. Arun Gulani. Arun Gulani is a surgeon who means business in the sense a patient who comes to an ophthalmologist comes with an expectation of seeing beautifully, seeing the best that is possible. Arun Gulani commits to his patients the best that's ever possible. I'm sure you are going to hear his techniques, his thinking, his approaches, his bold methods, and the results. And he also welcomes all of us to share our knowledge, our concerns, our doubts, and our so-called constraints that we may face while delivering to our patients, so that this could be one of the most interactive sessions. Dr. M.S. Ravindra always believes in an interactive and exchange of knowledge that should take place. And I'm sure this webinar he has designed keeping that in mind. On behalf of Karnataka Ophthalmic Society, I welcome you all to this great evening, and I'm sure all of you are going to enjoy each moment of this. Now, I request Dr. Divakar to welcome the gathering, and then we will be over to the scientific sessions. Dr. Divakar, please.
Good evening to everybody, and good morning to Arun from Vega. On behalf of the office bearers and members of Bangalore Ophthalmic Society, heartily welcome all of you to this great webinar. I welcome Dr. Arun C. Gulani, who is a well-known refractive and cornea surgeon from Florida. I think he has come to Bangalore Ophthalmic Society to give the Oration Award in 2016. At the time we had him, we were quite glad to listen to him once again. And he's the chief faculty for today's webinar. I also welcome other speakers from different cities and different parts of India who are presenting their own cases, who are experts in their own areas of work. I thank Dr. M.S. Ravindra and Dr. Deepthi who have arranged this excellent webinar in this today evening. I request Dr. Deepthi to introduce all the faculty and Dr. Arun C. Gulani and take over the discussions. Thank you very much.
Thank you. Thanks to both of you. Dr. Deepthi, you'll have to unmute. You need to unmute, Deepthi. Yeah.
Yes, 1 second. Dr. Arun Gulani is a world-renowned eye surgeon, founder-director of the internationally famous Gulani Vision Institute and global CEO of the Gulani Surgical Schools, headquartered in Jacksonville, Florida, USA. Fondly known by colleagues as a Da Vinci of eye surgery for his artistic surgical skills. Man of vision for his relentless pursuit of vision beyond 2020. And Dr. GQ for his immaculate dress sense and fashion, he leads elegance and artistry to eye surgery, leading him to raise eye surgery itself to an art. Yes, he is one among us, originally from Mumbai, India, and listed in the Forbes Gold Line Research among top 10 laser vision surgeons in the USA as one of the most famous eye surgeons in the world with a global clientele. Dr. Gulani is an internationally renowned for his innovations, groundbreaking innovative surgical techniques and publications. Dr. Gulani is a master surgeon, a teacher, an award-winning inventor, and an author who travels the world on invitation to share his passion. With an eye of an artist and a passion to help people see, he has turned Jacksonville, Florida into the vision destination of the world and has made India proud. We welcome you, sir, for this most awaited webinar.
Good.
So, Dr. Gulani, I thought for the person you are, only words won't make justice. So I could, do this video, and we were really, really happy to have you, sir, among us. So, very, very hearty welcome to this webinar.
Thank you. That's very humbling. Thank you so much. That was a fantastic video. And again, scares you as to how much of yourself is out there for people to grab. Social media.
It was very easy for me to get whatever snaps I wanted.
Absolutely. Again, thank you so much. That was really amazing.
And along with you, sir, we have a very eminent panel of very eminent doctors throughout India. So we have Dr. Himanshu Matalia, Dr. J.K. Reddy, sir, Dr. Namrata Sharma, she'll be joining us very soon, Dr. Praveen V. Krishna, and Dr. Rajesh Vogla. So we really look forward for a great discussion. And we have around 16 speakers. So as and when we come in, I'll probably introduce them.
Absolutely.
Let's start the webinar now. So Dr. Aditi. Dr. Aditi Agarwal, you'll have to unmute Dr. Aditi. Yes, Aditi, we can start on.
Dr. Aditi, we are not seeing your presentation. The voice is not there.
Okay, I think Dr. Aditi is having an issue. Can I ask Dr. Aishwarya to start loading? In the meanwhile, Dr. Gulani. So to start off, I would like to ask you 1 or 2 tips you would want to give youngsters. There are a lot of youngsters watching here. So we'll take a minute or 2 on this, sir.
Okay. Would you like me to go?
Yes, sir, sure.
I'm going to share the screen in a minute now.
Yes.
Can you see it now?
Yes, very clear.
Right. So the biggest thing I like to talk about is, Gloves Off is actually a series that Ophthalmology Times runs with me on a bi-monthly basis. And it's all about my desire to change the attitude. Again, the beauty of speaking in a webinar like this internationally, and especially all of you here, the surgeons are mind-blowing, your skills are amazing, so I don't need to go too deep into that. But I want to talk about attitude, how we approach things, how we stop limiting ourselves from what I call fabricated limitations. Don't scare yourself, and don't be slaves to technology. Unleash it. Think of technology as a horse you're sitting on. And I call it Marlboro Man. Think of yourself with a cigar in your And you have that ability and the look to it. And then finally, unleash your artistry, not just surgery. Important, artistry. I want you to look at all these corneas, all these people, these are worldwide patients, all day one post-op from different parts of the world, but the same look, the same comfort, the same vision, and confidence in letting them fly next day. Look at their corneas above you. All of these are 20/20 patients. And when I say 20/20, very important, please, we are all surgeons. When I say 20/20, I'm not talking glasses and contacts. I do not want glasses and contacts. Yes, they have a role in cases where you cannot reach after you have tried. There is no such case that you cannot do. If you have not reached because we're all human, yes, you give them a crutch. But I want that feeling of defeat to be there when you're saying that. For all of you here, don't panic. My entire team is building all my videos, all surgeries, etc., for you on our media, especially YouTube. So you can take this down. I'll have Dr. Deepti keep these links too. So you can go there and see all of this at your leisure whenever you want. Very important, I also teach, when you said youngsters, I still consider myself to be part of them, Deepti. Important here is the concept of how you practice. No matter where you practice, no matter how you practice, make the ambience like your living room of your home. No one cares if you're rich or poor, but how you make them feel at home is how a guest should be treated. That's how I look at my practice. I do not like people waiting. I don't like to be late. I want everything to look beautiful because to me, it's artistry. Everything has to look great. Even the color of my OR changes with the reason I change. My scrubs are that color. My instruments are that color. So I love that, and that's what you should do. And your patients will love things that you do. Again, remember, you don't have to wear a suit. That's just my second passion, is fashion designing. If you love to wear shorts and polka dot socks, do it. Your patients will love you because you're at ease with yourself. Everybody okay? So no need to invest in anything, just be you. So I always talk about premium concept. People have confused this premium cataract surgery. Giving it the word premium scares people. It just means being you. You are premium, remember. Let me remind everybody who's here. You were some of the most brilliant people in your colleges. So among thousands of people, you entered medicine. Didn't your parents celebrate that day? What does that mean? Not everybody could get in. It was privileged. Among the doctors, you're so brilliant, you became an eye surgeon. How many people become eye surgeons in your entire class? How about 3 out of 1,000? What a privilege. So all of you are already rock stars. Just be it. So the place has to look and be like you want, complete ambience control. It's your office, remember. You're not doing this for anybody else. It's your office. It's your home. Design the furniture, design the lighting, everything. These are today's patients. Again, my yesterday's article, for those who are just joining, in Ophthalmology Times, if you go Ophthalmology Times, GULANI, show me the patients. It's my resounding statement I've been making for 30 years since I was a resident. I said, I don't want to see anyone's surgery if they cannot show me the patient, loving them, being pain-free, want to hug them immediately after surgery. If you cannot show me that, I don't want to see your surgery. It doesn't matter. Putting stitches in the eye, throwing vitreous around, I don't want to see it. So these are today's patients. Again, all of these are my own dear patients. Minneapolis model, how she flew in for pterygium. Dr. Ravindra, you wanted to see a pterygium concept, so I'm going first there. Ocular surface, each pterygium patient of yours should look sparkling white next day. Next day. So the protocol in my institute is next day after pterygium, they're made to walk to a mirror. Even I don't know what they're going to say, and we record that. That's actually a recording in their chart. So next day post-op, these patients look phenomenal. These are patients I was telling Deepti right now, is how even when we are sleeping, your patients are evaluating you. This patient started her YouTube video before she came to me, after years of research on me. So imagine, even while I'm talking to her, someone's recording me. You cannot escape that nowadays. But again, you already perform well. Why fear anyone recording you? So she started a whole journey with me, recording everything. But what I say is, you don't have to get scared of such patients. In fact, these are the patients who will appreciate you. Only an artist will appreciate art. Now, she is one of my, like all my patients y'all have seen all over the media, because we don't advertise, they write. She actually, patients call her and question her via email and via text. Is Dr. GULANI real? Is these results real? Is this all advertising? And she has to answer. As a patient who I don't give any...
Unmute now.
Hello? So this is important. Your patients become your own Soldiers, I call them tornadoes, your ambassadors. By not seeing our patients next day, we are missing that opportunity. Let them hug you. Nowadays, I know COVID will make things a little different, but let them hug you. Let them tell the world how you treated them. So this is, again, you see a patient down here on the right. She's been recording her pingecula every day, every month on Facebook without my knowledge. Can you imagine how accountable you are? And that's the book we just released. Again, patient experience, the patient, how they come, how we meet in pre-op. Even if doctors are watching all the time in my surgery suite, I never let the patient feel that she is being watched. It's always patient and you are one unit. Complete focus, meditate. Surgery is not acrobatics, it's meditation. You're returning their trust in a currency called vision. This is how pterygium patients look next day. If you see how they post their pictures online, social media, they put the before, after, you can see the white appearance exactly and how they show their appreciation. This is the future of ocular surface surgery. Better be ready. So a pterygium case, again, you don't have to have anything special. Your surgery has to be different. It has to look like this. No recurrence rate, 18 years follow-up, painless, no cautery. So again, I'm busting all your myths. It doesn't matter if you operate in a village or in a surgical center, there should be such little bleeding because you're using your blade as an eraser. All right? That's the book. If you all want, please. No financial again, but Team has published this new book that we've written on pterygium, all my experience with very excellent surgeons for your perusal. Surgery for Dr. Ravinder's request here. This is a patient of moderate pterygium. She's been sent to the recurrence.
Recurrent pterygium. And we are
I'll go a little fast just so we go through systems rather than see the whole surgery. That's the fixation stitch I take on the side. You can see how I mark it. This is the most important thing. I go after the tentacles of the pterygium. That's the reason you don't have a recurrence. You see how I'm pulling with my left hand and cutting with the right? You see how the pterygium comes into my left hand without me doing anything. See, even with this recurrent case that was sent to me, there is no bleeding. Minimal bleeding, if at all. That's the beauty. That's epinephrine swab going in, also creating a space for my amniotic graft coming up. Now look at the mass. This is why I call it the iceberg concept. It's about 4 times the size of what you see. If you don't remove it, recurrence is imminent.
You can see the medial rectus.
You must see the middle rectus, otherwise you haven't dissected enough. See how I use the blade. So you don't cut. Mitomycin for Dr. Ravinder, you said mitomycin is not being used. Mitomycin has to be used between the conch and the tenons, not on the sclera. Again, see it here, and then I also dry the sclera. I must put it in between the conch and tenons, not on the sclera. That's the important thing. And I use it in every case. Hold it for about 30 seconds, flush it out completely. Take the amniotic graft here, subamniotic, 1 drop of epithelial glue, spread it out. Everything excellent, controlled. No movement of the graft, never had a slippage. Patient next day, painless, wants to walk up to the mirror. This is their expressions next day.
You can go up to the mirror. Okay, I'm ready. Crossing my fingers. Oh my goodness. You don't have nothing.
So I want you to get addicted to these things, please. How the patient looks next day, because that's how the surgery goes. And of course, they can't express enough happiness. Now, I'm going to show you surgery, a few surgeries just to show you mindset and what I call extremes and limitations. When do you really do a transplant? And never a penetrating transplant. Never a penetrating transplant unless there is a through and through perforation into the eye. So if you go into cases like these, again, remember, most of these patients, nearly all my patients, extremely demanding, extremely high IQ, but still you become a team with them. You don't get scared of that. Patient with, this is a surgeon with extremely bad scars, blinded, RK with arcuate cuts all around in a circle, multiple deep 2-3 times done RK cuts. This cornea is a mess. Even if I could have fixed it with laser and corneoplastic, I do need to build this cornea. Again, no PKP, because my final plan here is, he's in his late 60s. I want to plan cataract surgery intelligently. So see where my plan is. My plan to take him to Paris to do his cataract surgery, but first we go to Iceland to do this part. Otherwise, if I do cataract without measurement of this cornea, I have committed a crime. So this step has to be done. So this is a case where I would do a lamellar, hand lamellar surgery.
With dense central blinding crossing and deep open arcade cuts.
So if you see, again, topography is not important. I'm just showing you for discussion.
With crisscrossing and deep open arcade cuts with high irregular astigmatism of over 15 diopters. And I planned an anterior hand lamellar.
No machine will do this. You have to go by hand. It's a very simple tooth blade that I have modified into multilamellar techniques. Very simple. Again, the cuts are so deep, you cannot trephinate because you'll break the cornea. It's so many crisscross cuts, not just a simple RK.
Dr. Gulani, it's not playing now. Mr. Gaurav?
Sir, is internet getting
the cornea here, through the feed supply, through the cornea, through the donor, and coming out. And yet I don't want astigmatism. So that's in my mind as I'm stitching. Star suture, we are done. 6 months later, we go for cataract.
Pre and post, and thank you for your attention.
So what I want to say is, first of all, there's no limits. Don't get worried by these topography astigmatisms of 20s and 25s and 17. Here you can see a patient from Abu Dhabi from 10 to 0.1 diopter. We'll talk about this later, but I want to make sure I break this myth about topography and getting scared about what you see. We'll come to this later now. Do you want to present?
So your video get freezed.
Hello?
Yes, Dr. Gulani, we just lost you for a few seconds.
Oh, you did? All right. So my question was, I was going to go through this few things and then stop. You all can present. And then we go to semantics from here. This is a case where actually I'm going to talk a lot about how you think, not how you operate. So some of you have seen this in my other series of Top the Train Wreck, but it's important for the youngsters here who are trying to still look at surgery is how I don't think surgery at all. So here's a gentleman in a lawsuit with his surgeon, keratoconus left with hyperopic surprise, high keratometry of keratoconus, 49, with central anterior scar, premium lens, and the doctor opened up his PC trying to help him, which was not a great step. So now you're stuck with this gentleman. He's a pilot. He cannot do anything. He's farsighted, cannot read, has cone, scar, high case, and open PC. So Deepti, what would you do? Would you like me to repeat the history? Keratoconus with anterior scarring, high keratometry, 49. Patient has pseudophakia with a hyperopic surprise, +2, -2, and PC is also open. How do you get him to 20/20 now?
I cannot see the K reading, so what is 47?
49.
49. So only a laser would certainly not work because it's just around 460. So three things, probably central cone. We could do an intact, or the PC rent is there, so probably not an IOL.
Not bread, it's yak capsulotomy. The surgeon did a great surgery, but wrong outcome. Yes.
Okay.
Good. Yes. So the PC is open.
So probably no lens manipulation. So an intact, and probably put a second lens inside, maybe a sulcus fixated lens or something to correct the residual. I'm thinking bold like you, but I would put him on a contact lens. I do a lot of lenses, so I would put him on an RGP, but I'm sure you have a different take on that.
So Deepti, let's for this discussion at least make me happy. Don't talk about anything other than correction. I don't want contact glasses in this discussion. Please, again, they have a role, absolutely very important role of optometry, contacts, and glasses in cases where we cannot, despite surgery, reach our goal. Are we okay? That's the only indication for that. Don't accept defeat and put somebody in a crutch. Cannot do that. I love your thought process where you went. Yes, do cross your limits. Now, number one, everybody can hear me?
Yes.
Clear.
Number one, I don't even look at the topography, so I like it that you saw it, but I don't want you to see it. Second, you talked about laser cannot be done, Deepti. Why was that?
Generally, my cutoff would be just around 50 microns, and I would want to leave at least 400 microns untouched in a keratoconus.
So Deepti, again, today I'm going to cut off your cutoffs. All right? So first of all, you're not thinking of doing LASIK on keratoconus, are you?
No.
Lovely. So your cutoff doesn't matter. Am I right?
Okay.
Second, this is a hyperopic case, remember. So your cutoff doesn't matter. Am I right?
Yes.
Lovely. So you're there. So even if the cornea was 350, I didn't want that discussion because it's hyperopic. Second, you never cut the cornea, remember, in a K cone. So no LASIK, so the cutoff doesn't matter. Three, keratometry is high. So put that in your mind somewhere. I have to decrease the K. All right? Now, also have to correct the anterior corneal scar. It's anterior superficial, typical of cones. Correct? The only surgery I can do here that'll get me all my problems done is myopic laser vision surgery. It'll decrease my K, it'll decrease the scar or remove it completely, and correct my emmetropia. Here's my problem, Deepti. The patient is hyperopic. So now see what I do with the patient. Mr. Smith is already angry. He's going to sue his surgeon, one of the most brilliant surgeons in America, who's done thousands of LASIK. And when he flew this patient, he was in severe fear because patient was sued. See what happens to the patient after we meet, and I talk to him. I said, listen, my plan or concern here is how do I make you myopic? I know I can fix you. He relaxes. Now he's not angry at his doctor anymore. I say, I know I can fix you. My problem is how do I make you myopic? Now all my fellows and surgeons who are visiting go, what is this guy thinking? Dr. Lani, what are you thinking? I mean, you're very skilled. Why don't you remove the lens and put a secondary lens, play with the vitreous, do an amazing job? I'm like, no, that will cause inflammation. We are doing too much work. I want 20/20. Remember, Deepti, we don't want to go away from 20/20. So I tell the patient, I want to make you myopic. That's my only problem. And the patient goes, wow, doc, how will you make me myopic? So he loses his anger for the doctor and becomes your team. Very important. You have to have confidence now. So now he's on your team. So I tell him, all right, here's what we'll do. Because your PC is open, I'll put a piggyback lens in. And you have a deep chamber. Remember, Deepti, keratoconus eye. Deep chamber, no fear of endothelium. PC is open. I can easily put a piggyback lens, takes 3.5 minutes, same incision, topical. Yes, agree? Now I made him myopic with his residual astigmatism and scar and high K. Are you with me?
Yes.
I wait for 6 weeks. I measure till he's stable. This is what I call, I'm taking you to Iceland before I take you to Paris, but the ticket is to Paris. With me?
Yes.
Now I come in 6 weeks later and we look like a hero. 3 minutes laser surgery, the guy comes out crying, 20/20. His K has gone down, central myopic. His scar is gone. His night vision is improved, and he's 20/20. Last time he emailed me, he was 2015. He got a pilot's license. What does the patient remember? 2 surgeries, 4 minutes long, topical. No barbaric circus acrobatics. Correct? What did I just speak about, Deepti? What did I say that you did not say?
I'm sure there'll be a lot of options. We should not give up. And that was really an out of a box thinking. What how you manage this patient was excellent.
So we do not think surgery. And the point here is, again, all of you are excellent surgeons. We're not talking about surgery. It's the thought process. If I had to think surgery, I just have to display my level of skills and put this surgeon to shame. That's not what we are here for. How do I take this angry patient to perfection? Let him go back and hug his surgeon in New York. That's the plan. And the patient has to reach 20/20. So once you start thinking this way, you have to exhaust yourself. Think, first, don't give up. No contact glasses. Don't say your surgeon is bad, you had a bad job. No. It's okay, let's go. Here's my plan, Mr. Smith. Now, Mr. Smith has to have so much confidence in you because he's paying for a ticket to Paris, right? He wants to see the Eiffel Tower. And he took him to dark and cold Iceland first. He put a piggyback lens and he went to 2200 vision because he's myopic now. He hates you. But you have to have that confidence now to land again. And this time exactly at the base of the Eiffel Tower. Are you with me, everybody?
Yes.
So you're getting my point where I'm going here?
Yes.
We're not talking surgery. The surgery, anybody can do. A first-year resident can put a secondary lens in. Yes, piggyback. And a first-year resident can do laser surgery. No big deal. Thought process, 20/20. So that's what we did here. And that's where he is today. So this is very important. I call this top the train wreck. See the S is small? Don't come across to a patient like, I'm going to help you. Oh, I will try my best. That's losers' statements. So, hey, Mr. Smith, come on, let's go. And in your mind, tell yourself you're going to top the train wreck, okay? This is my brain. This is how I think. Even a simple myopic patient, if you send me, I think like this: sight, scar, shape, strength, sight. Sight means does the patient have vision? If the patient has vision, and you can even do this with a hard contact lens trial, correct? Are you guys with me?
Yes.
If you cannot refract, which is my most important thing I'll show you today, hard contact lens trial over refraction. You want to find what I call the gold, the potential to see. Once they have potential to see, you're on the line because you cannot let go now. So sight, scar, shape, all refractive surgery shape, you agree? Flattening, steepening, football to basketball. Strength, thin, thick, site of involvement. Periphery doesn't matter, central matters. So even if you take a myopic case, it falls into shape and you see what you do, laser. You take a scar, you give me any case, an entire refractive premium cataract surgery, you put it through this, what I call brain sorter. You know what a coin sorter is? You throw the coins and the cents fall over there, the pennies, everything. Yes? That's how my brain works for any case you give me. I do not like to call it names. Keratoconus, LASIK ectasia, epikeratofakia. That scares you and the patient. Make it simple. I'll define keratoconus for you. You ready, everybody?
Yes.
A relatively thin cornea with high keratometry, associated with myopia and astigmatism, sometimes hyperopia. Can you tell me anywhere I missed my definition? You see what I just did? I took 11 feet tall giant, keratoconus, and I broke it down into pieces. All it is relatively thin, relatively high K, myopia, astigmatism, sometimes hyperopia. Am I right or wrong? Now you can bring out your nunchuck like a Bruce Lee and go break its back, because all those things are correctable. And you'll see that when we go to K-corners. So again, here's another patient, and this video I made for you, very special again. As you know, another myth buster, herpes cornea can be worked on. All herpes cornea, I've been doing it for 20 years. There's been no recurrence. I do give them Valtrex starting 2 days before for a month. I don't know the real effect of it, but I do it anyways. Here's a patient, blinded, count fingers, with herpes scars all over his cornea in a cataract age group, left for nothing to be done. Astigmatism 24.7. Deepti, do you think I care for this topography?
Now that you said you don't, so I'm assuming you don't.
I don't. I'm just showing it because that's how we converse. So here's the surgery I'll take you straight to. So here he is. You can see the herpes scar. Cornea is down to 300 micron, doesn't matter. See the depth of the scar. See this vision, 24 diopters. And herpes, don't forget, please. And I've just done his laser plastic. I put a BCL on. And then I plan his cataract surgery. And if you see, I leave cortex behind in the subincisional area for future opening the bag. See the cornea, how diseased it is. But then I go with full confidence after refraction with the toric premium lens. That's the level of confidence. Okay, right on axis, you can see the scars. Topography is still 24.
Hi, good morning. How are you?
This is the next day after surgery. Very important. No pain. No pain. No pain. Completely clear.
All right, Terry.
Now watch what I'm doing.
Extensive...
Very important here. This patient came from count finger. I did laser plastic, shapened his cornea to what I call measurable cornea. Otherwise, you don't dare enter for cataract, please. It's not about can I do a cataract through a scar. It's about how accurately can I do cataract. That's the reason he's depending on you. So we went in, and when I did the cataract after my cornea was measurable, I still went aphakic because I wasn't sure of the measurements. So I do what I call aphakic surgery. I remove the lens, then I measure them next day, refract them, and refract them a week later. I go with that knowledge and I put in a lens with such confidence, he reached 20/30. Again, 4 minutes laser surgery, 4 minutes cataract surgery, 20/30. Now here's me and him, type A people. He insists, Dr. GULANI, I know you can do more for me. Now imagine, count finger guy, already we took a huge risk with laser on his herpes cornea. So this is where ethics come in. Patient may say, Doc, I want this and I can afford, but you have to be very ethical and strong. We'll talk about this later during premium surgery. Here I am again refracting. Guess who's refracting all the patients? personally. Very important, very important. Now, this is after he's 2030. So he's saying, Doc, let me see if you can help me more. So I refract him and see where I'm going. I do what I call perception test. Watch that. But I've refracted you, and we're going to see if you see any difference there. All right? Okay. Here we go. Can you give me anything there? CCD. Wonderful. Anything at all? Come on, try and read some more. Imagine he's reading, first of all. Oh, lovely. Look at that. So you move straight from legal blindness to vision. I'm very happy. 24 diopters, Deepti. Remember topography. Read that backwards now. Come on. So now I'm pushing him, reading backwards, making sure he's not lying. One more thing as we are doing this. Eyes wide open. Perfect, perfect, perfect. Streak retinoscope, streak retinoscope, streak retinoscope. Excellent. Look over there. A refractive surgeon must know how to refract. Nice. Wonderful. This is the biggest trick I teach surgeons, the ability to refract. This is through his scar, please. He still has a cornea that looks like garbage, but he's reading 2030. Test, I call this. Cover your left eye with your hand, Terry. This is a very important test, perception. Because it's I can see it, but not very well. So he's seeing it, 20-30 line, and now with my refraction. Give me a number 1 to 10. How much? Give me a number. 10. You see that? That tells me it's worth doing the surgery, worth spending money, worth doing surgery. Excited? Yes, sir. Patient's trust.
I'm ready to do that.
Very nice. Excellent. Prophetic scar. Yes. Right under the laser, these patients see. Yes. Can you see that? Coming out, no pain. The eye, but there's having a limitation. Same with him, what we're doing. Patients, this is him, this is my $1 billion payback, I call it. But anyway, quickly, why was this important? So this case was important to show you, first of all, not once, we went twice on his herpes cornea, no recurrence. That's a risk. That's a risk. But your confidence is also to be matched by your ethics. He could see 10 on 10 difference at the 20-30 lines with residual refraction, because now I could refract even more accurately. We went through 3 things with him, all of which he needed. First, I corrected his cornea. Then I did his cataract, which he really needed. Then I came out and we went overboard and got to 20/20 minus, again, without glasses. Are you with me up till now, guys? So you saw me break all the myths, no topography, refraction, persistence, the patient becomes your team. Remember another thing, please. I've said this before. All the patients I show you, every surgery of mine has my patients in it. There cannot be a higher accountability. You can show a graph, a white paper, all that can be fudged. A patient who's paid for surgery on camera, there cannot be a higher accountability. And you can see the patient is part of your team. And remember, these patients have already had bad outcomes with doctors. So their trust is low. How come they become so fun? Because they see a genuine desire. So that's also an important lesson in this story. Then you saw him come next day, no pain. I don't know where people talk about pain with PRK. I have never seen it. Another discussion, myth buster. But you saw herpes case, we went through into the eye, we went responsibly. To do a cataract through a scar, a carpenter can do that. But to do it without calculating properly, criminal. Are you guys agreeing to what I said? Very good. Now, should I go here? Let's finish this case, then we'll come back. So here again, Deepti, let me take you. This is pre-op topography, 8.9 astigmatism. Look at that, colors. Things that these colors are so attractive to doctors, right? This is a one-eyed patient. I'll repeat, one-eyed patient in his late 30s, 8.9 astigmatism, herpes corneal scar. And he works for Valiant, the company for Bosch and Lam. He knows every eye surgeon on this planet. He's been to nearly everybody, different countries, he's been everywhere. What did they say? Deepti, what option did they give him? What would you give him? One-eyed patient, herpes scar, 8.9 astigmatism, 3 kids depending on him, young man, knows every eye surgeon in the world. What's your options? Hello? I can't hear you.
Yeah, sorry. We lost your screen.
My screen?
Yes.
No, the screen is there. He is there.
The pentacam?
Can you see me?
We see you, but I don't see in your screen share. Do others see the pentagram?
No, he has come out of the share.
Yeah.
That's it. Let me see. Share screen. Yeah, I don't know why it jumped out. Share screen. Here we are. Share. Okay, now we're back.
Yes, we are back.
So,
So I saw the topography, but how is the clarity of the cornea? So is it, the opacity is what grade?
again, grade. I love this.
Is it a macular, nebular, or what grade of scarring is it?
It's horrible. How about that one?
So it's
Yes.
an opaque cornea.
Yes, but I can refract through him.
You can refract through him.
Yes, I can show you the picture, but I won't because I want to break this cycle of grades. You'll have severities for everything that scares you. Listen to the other thing I said. One-eyed, herpes, scar, 3 kids depending on him. Saw every eye surgeon on planet Earth.
This is a different cornea. I think this is a 231 micron cornea, which is on the screen. This was the previous case, I guess.
Yes, here you go. Yes, here you go. Okay, let's go for speed of time. What am I doing here, Deepti?
Refraction.
I don't care what the scar is. Are you getting my point?
Okay.
I don't care how the scar looks. I'm personally refracting him, sweating for half an hour. Watch this. Please, this is very important for you guys to see. Very, very important. Oh, sorry, play. Okay. That was your pre-op, right? Okay.
RHKSD.
Only seeing eye, left eye.
VHOZ.
Now here's
Don't make my day. Give me the second last again. It is correct. Yes. Fantastic.
So my point here, nobody, he saw, I think, 16 surgeons all over the world because he knows everybody. Not a single doctor refracted him. Why was that, Deepti? Because same thing. They gave him grades of scar. They gave him scary numbers like you have herpes, so much % recurrence. You are only one-eyed. I don't want to risk my license. Go to so-and-so doctor. 6 of them referred him over here. My point. You don't care. Every patient to you is human. He has 3 children, I told you. He's in his late 30s. Look at how young he is. His only eye. Why would you become a doctor if you're sending him home? Are we clear, guys, where I'm going with this? I don't want excuses. I don't want any stupid classification in papers that are sent to me. Grade 2, 3, 4, 5. What does that grade mean to the patient? He's telling you he can't see. Are we clear? I refracted him. I was blown away. He was blown away. He could read 20, 30 minus. What do I call that, Deepti? Gold. Are you with me, guys? Suresh?
Yes.
Gold. Now that I have found my gold, we can't let go. Because you have to give him at least 20, 30. You're responsible now. Clear? That's what we did. He came out to be 20/25 vision. Till today, he sends me his photo on his anniversaries and children's birthdays. He was last skiing with his one eye. He drives to me now 6 hours just to say hi. Can $1 billion make up for that? What's the lesson I'm trying to say here? Everybody got scared because he's one eye, herpes, knows every eye surgeon. Oh my God, lawsuit. Doesn't happen. The patients come to hug you. Very important. So don't give up on the positive. That's my point here. Here he is, amazing guy. That's the scar, Deepti, for you. What's the grade? But you're getting my point, Deepti. The point here is the grade doesn't matter. Start refracting. And what I want you to believe, understand, and do. I'll show you crazier scars. If anybody here dare tell me that they've seen a bad scar, I'll show you worse 10 times scars. I refract everybody. The point is, you're not going in with a bias. You're going in with, I can help this guy. And you are doing it. So no excuse. My technician didn't get it. No. You get into that room. Don't come out for 30 minutes, please. That's what I tell my fellows. I want refraction. If there's a dagger in someone's eye, I still want you to start refracting. That gives me enough reason that you failed. That's my attitude. Okay, guys? So that is another case. for you. And that's his post-op. This breaks another myth for all of you. Topographies are not the direction to go. They are something you look at and understand, but topo-guided surgery is a complete myth. I'll show you thousands of patients I've done. Look at his post-op topography deeply. His astigmatism is just 8.4 from 8.9. So what did we do? If you look at topography, nothing. But what did we do? We changed his life. Count fingers to 2025. You guys get it now? Yes. Correcting topo-guided corneas is like tailoring a suit, looking at the mirror image of a man. The guy in front of the mirror is looking baggy and ugly. You're trying to see the mirror. Are you with me, guys? Yes. So that video line is called Man in the Mirror. Michael Jackson. Everybody knows the song? Yes. Great. Let's go. So now I'll stop. We'll take some cases. Or do you want to see this? This is a case of combination concept to show you that there are literally no limits, period. Okay, let's do this. Then we'll come back and maybe you can present some. Then I'll take a break. So again, here we'll go. Suresh or anybody who wants to jump in, please. Dr. Ravinder, who's the cornea refractive person here? Anybody?
Dr. Himanshu would like to comment on this?
Sure.
Dr. Himanshu?
Yes, I'm there.
Dr. Himanshu, great, excellent. So here's a patient with 9 problems in her eyes.
Okay.
Had hexagonal keratotomy, has 23.5 diopter astigmatism, has over 69 keratometry, has ectasia, has Fuchs dystrophy, has PSC cataract, high myopia, exophthalmos, amblyopia.
Okay.
What would you do?
So this is the only eye, or we have the other eye also, which is normal?
Doctor, to me, every eye I operate on is the only eye.
I mean, that's a very nice attitude, but
Pardon me, that's the only attitude.
Yeah, sure. So I'm talking about something where you want to pay attention. So it's very interesting to have a 20/20 vision in one eye, and if you have a gross difference in the refractive error between two eyes, then possibly the effect to the patient is as good as not anything, because the patient is not using that. That's the reason I ask you. But anyway, let's come back to the case here. So patient has come for the cataract surgery. And as I can see from here that the astigmatism, which you have significantly high astigmatism, but very interestingly, pretty regular astigmatism to me. And though the pachymetric values are a little dispersed, but it's not as bad. So if my endothelial decompensation, which is not obvious, I seriously won't worry about it too much. And especially if it is not changing the pachymetric profile, that's the last thing on my mind. Now, I have to look at something where what can I do minimum to visually rehabilitate patient? To me, I have to have something in my mind, which is my terminal goal or last goal. And as you rightly said, for you, if the last goal is 2020 or 2010, well, then I have to start, how do I reach there? If I start with my goal that if I have to reach 2020 with minimum intervention, which I can do, then possibly that would be the best treatment. We can surely do many intervention. And if we can do it with the minimum intervention, well, possibly I would be really happy. To me, such kind of cases, I would think of a customized toric IOL, and I would go ahead and reduce the astigmatism sometime. I would show some cases like this thing, and then we can actually get rid of the entire astigmatism. We can give him significantly good vision and as good as 2020 or 2025 or something like that. If after that, whatever residual I have, then I have a chance to deal with that thing using my laser platform, that how I can refine this thing, whatever I've got, to my acceptable level, and which can give him the best vision. Now, we can stop at any point of time, because the maximum part which we have to do, we did with the first surgery. Now, if patient says that your patient is more demanding and he wants to get a step ahead, we go ahead with this laser refractive surgery, next step ahead. But if Dr. Ravinder said, if patient is very satisfied that, okay, you know what, I'm fine with 2025 or 2030, well, we stop it there. So that's what I would think about.
So doctor, I like the first part of your discussion where you explained, and very rightly, minimalistic intervention, and the goal comes first. I call that target, then technique, then technology. Here is where it's completely wrong what you said. You forgot that she's ectatic, cannot be measured, and everything is beyond the realm of cataract surgery here. To enter and do cataract surgery through a non-measurable cornea, to me, is completely off track, because you've done a very sacred entry. You entered the eye now, and you have no way out. It's irreversible. Again, yes, we can reverse the lens, doesn't matter. So first thing is to make sure the cornea is sensible. By sensible, I mean make it measurable. How would you measure the lens in this eye, doctor, if you had gone in the way you did? There's no measurability, there's ectasia, there's fluctuation. How will you measure?
Why would you worry about the length? It's not going to change the length of the eye.
Not the length, doctor. How accurate are you with the lens? There's 23.5 astigmatism. There is high myopia, and there's ectasia in the cornea.
If I look at this cornea, most of the irregularity, what I'm dealing with, is related to an incision, which is mid-peripheral incision. So I do have untouched part in the central cornea, which I would be quite okay to rely upon. Now,
hold on, doctor. Hold on. No. Your cornea, the problem with Hex-K, unlike RK, is it makes a central island of instability. The whole island is moving. Every day there's a 5 diopters here and there. So that's the problem here. Plus measurability. There is no machine that measures through this.
I got your point. Now, by default, we assume that we are talking about when we have reached a time frame where it's stable refraction and
stable.
Stable.
If Hex-K gets stable, and this kind of Hex-K, this is called a spiral Hex-K, it never stabilizes. The poor patient has been left blind for 60 years.
So if I feel that I don't have a cornea which is stable, then possibly there are 2 ways to go about it. One, we have to stabilize that cornea. You can stabilize the cornea in 2 ways. One, you take care of the incision first, so that you close down the incision and taking sort of a purse-string suture, wait for it to stabilize, wait for it to change its appearance, how it's looking, and then go ahead and go for the second step. If that's not possible, the another thing which I would think of would be a lamellar keratoplasty, take care of the larger diameter, this thing, and place the cornea, which becomes a little more stable, because now you remove the area which is mid-peripherally ectatic and leading to the central part of ectasia. Again, there are different ways of treating same case. There cannot be one uniform way which we can say that this is possibly the only way.
So doctor, I will change your mentation at the end of this meeting, but here's what we'll do. I love the fact that you went in the correct direction now. Cornea has to be measurable before going to lens. Stitching the thing is completely inaccurate, should not be done in such cases. Lamellar surgery is a backup. Correct. Wonderful point. Here's what we did. There is only one option for every case. That's the biggest thing I want to talk about today. That's why you are here to just punch me left, right, and center, because I will not let you give options. One way to go. That's why patients are not confused. You are not confused. It is not a menu. This is not a restaurant. They're coming to a doctor, one way to go to 2020. And why? So beautiful. I love your thought process. Let's go into it. My thing here is, I want something that will hug my cornea, the island, and stabilize it. Hug it and make a new boundary for it. The boundary right now is unstable because the Hex-K is deep and the cornea is wobbling. So that boundary is, I thought of intact. So I took the rings and I put it very carefully around the Hex-K. Now I have created a new wall, stable, measurable. And I aimed it in a direction of astigmatism and landed at 1.4 astigmatism, corrected my boundary, measured her for 3 months repeatedly for stability. Now, I don't like cross-linking ectatic corneas immediately with any surgery because you're creating a cocktail. But because I do intact in a titratable technique, you'll see the reflex becomes a circle. I cross-linked her immediately. 3 months later, we planned her surgery and then went in with a T3 toric lens, the lowest toric lens, to 2020. Again, minimalistic, very good point. Cornea first, lens later, because you want to not enter inaccurate. Cannot afford to go inaccurate in the eye. So thought process excellent. This is what we did. You can see the astigmatism down to 1.4. More importantly, you've created a new barrier, a new cement wall around the hex K. Now I don't care for the hex K. And very good, doctor, the center is clear, so I have to do nothing there. And that's how you go in. And then we go into her surgery.
This is a 75-year-old nurse who was referred to me following hexagonal keratotomy with corneal
again,
ectasia,
surgery not important,
vision of
the
count
process
fingers
of thinking
only,
behind
and Fuchs dystrophy, along with associated cataract and high keratometry of 88 with high irregular astigmatism of 23.5. I planned first to stabilize and make her cornea measurable.
So this is a difficult step around the hex K. If you make a mistake, you go in.
Here I am using Intacts, and as you can see me, I'm using her own corneal resistance to guide my
no cutting,
resistance,
push.
I'm doing this without any sharp intervention, so I don't make mistakenly any incision that can go into the hexagonal keratotomy cuts and perforate the cornea. Again, notice these are very determined yet very careful movements of the ring, and I'm placing them so as to embrace this central unstable island. The success of this is immediately reflected in the central light reflex.
Please look at the central reflex.
Which is becoming more and more circular, and I call
this is very important. This is what I watch.
Concept of
many patients can tell right then that they are seeing much better already. It's an immediate. I'm cross-linking. I never do that simultaneously, but where I'm so happy, I track it.
From 23.5 to 1.4 diopters.
Look at the patient dressing up next day after 60 years. Look at her.
Dressed next day to meet
Exophthalmos can still be seen.
4 months after determining stability of this
4 months
cornea,
later,
so we can determine accurate cataract surgery. We proceed here. Trypan blue for the observing surgeons. Viscoelastic
again,
exchange.
all these surgeries very simple for you.
To be a smaller size, so I can see the edges between the hex K cuts and the intact
manual to keep the rexus small.
And also
it's
to
a high
maintain a good
myopic
lens
eye.
and capsular diaphragm.
And I don't want to stitch. Don't want to stitch. My brain's constantly. I don't want to stitch.
Which is doing cataract surgery also in determined steps. Like you see, my phaco probe is not moving. It stays in one place while my second hand does most of the movement to maintain a stable incision. Similarly with the IA and lens insertion here. Lens is now being placed in the bag and then gently moved into its axis. Again, irrigation aspiration, well-sealed incision, further reinforced with Resure sealant.
Don't need
no
it.
stitch to induce any
astigmatism.
astigmatism.
Use it in this
so
case,
here we have taken a patient
twice.
who was denied her vision for 60 years. In few minutes surgeries, 4 months apart, we have restored her vision and her confidence to give her back her life, where she's come back to nursing and helping other patients.
She became a nurse after
Here
this,
she is immediately after surgery, and here is my payback, seeing them smile and free to lead their life and help others. Once again, thank you for your attention.
So, doctor, that was excellent discussion, because I loved how you went from least interventional, target 2020, walk backwards to the surgery, and also, had I failed in the intacs, lamellar keratoplasty would be my backup. Absolutely correct. And the channel of the intact would be my starting point. So I wouldn't even need a special instrument for that. The channel of the intact would be my lamellar plane. I would do that, put a lamellar graft on top, do a running anti-torque 8-bite suture, leave for 6 months, come back, do my cataract, and then do laser. It'd be 3 steps then. But the point I'm trying to drive home, even in cases like these, is surgery was so easy. All of you don't know how to do intacts, know how to do cataracts, the planning. And what I'm trying to do here is giving you all the opportunity to keep countering me is no options. She got a simple plan. I'm going to use the rings. It could be Kera ring. It could be whatever you have, wherever you are, Ferrara. Doesn't matter to me. I wanted a new wall. I'm going to put the rings for you, ma'am. If I fail, I will do lamellar keratoplasty. We are after your cataract. You do understand it's difficult. Of course, doctor. Nobody has done this for me. Great. We're going with a plan. So that's the concept. So again, doctor, love the conversation. Lamellar is your backup. Absolutely correct. But the fight for her vision is relentless. Do you all want to present now or wait?
Yeah, thanks, Dr. Gulani. It was a wonderful session, but we have already covered 1 hour. We have a long list of presentations, and Deepthi, you can start doing it.
Yeah. So we would call Dr. Sharon and Dr. Aishwarya.
You'll have to check out of the, okay. You'll have to come out, Dr. Gulani.
So I invite Dr. Aishwarya and Dr. Sharon, who are from Narayan Netralaya, to present their case, please.
Right. So good evening. Good evening, everyone. Dr. Gulani, a pleasure to be on the same forum with you. So we're presenting a very interesting case. Dr. Aishwarya would be presenting, and this is on behalf of Dr. Rohit Shetty from Netralaya. So it is a scar, and I'll hand it over to Dr. Aishwarya, who will run us through the case as quickly as possible. Yes. Thank you.
A very good evening to all of you. At the outset, I would like to thank Dr. Arun Gulani and my mentor, Dr. Rohit Shetty, for giving me this wonderful opportunity. So this was a 25-year-old female, history of both eye LASIK done elsewhere, and she came with the complaints of blurring of vision in the left eye. The vision uncorrected was 20 by 200 and best corrected was 20 by 50 with a minus 2.5 diopter of cylinder. This was the slit lamp photo. Probably because of a flap loss, this was the image, which involves a scar over the cornea. Mammography revealed a 20 to 30% of gland loss. When we measured on anterior segment OCT, the scar depth came out to be around 130 microns. The quality of vision was poor, and because mostly it was contributed by corneal astigmatism, and there was a localized irregularity on the topography. So what are the treatment options? We can do a phototherapeutic keratectomy, but that would lead to an excessive tissue ablation and hyperopic shift. A keratoplasty will have its own set of complications. So can we do something else here? This is a novel technique where using the PTK cam module of the Schwinn-Damaris, we measured the dimensions of the scar. We also introduced an offset, which was to decenter and localize the ablation only to the scar area. And we created a customized decentered ablation profile, and thus ablation was done over the scar area. Postoperatively, the cornea looks much clearer for post of 1 month and 3 months, and there was a significant visual improvement. So left eye, the uncorrected visual acuity improved to 20 by 30 and best corrected visual acuity improved to 20 by 20 with a minus 0.25 of cylinder only. Corneal topography revealed a flattened topography in the paracentral temporal areas, overall regularization, and there was a decrease in the corneal aberrations. Of course, there was an improvement in the quality of vision. And on Society postoperatively, there was stromal regularization and scar density was reduced. Thus, we can do customized PTK for corneal scars. It leads to regularization of the epithelium and the stroma with less hyperopic shift, less tissue ablation, and a very quick visual rehabilitation. Thank you.
Great. That was a great case, Aishwarya. So next would be Dr. Ramurthy. Before that, if Dr. Praveen is there. Hello, sir. How are you? Welcome, Dr. Praveen. So you or Dr. Himanshu, anything to tell Aishwarya? Aishwarya, you'll have to stop your screen share. Yes.
Yes, I've stopped.
Yes, thank you. So Ramurthy, sir, in the meanwhile, you could start your screen share.
Well, nice case and nice presentation by Aishwarya and Sharon, but you guys know what we're going to say. So I think we'll all be very keen to hear from Dr. Gulani what his thought process would be. I think that would be much more interesting for all of us.
Sure.
So let's move on with this. Aishwarya, excellent presentation, and I love the fact that you're addressing these cases. That's point number one.
Thank you, sir.
Himanshu said something, I want to get back to that. That is an excellent point. Here's how I would first approach this case. If you saw me, and if all of you understood now, I would refract this patient personally. No digital data, streak retinoscope. Getting a minus refraction is like someone gave you candies on a tray and said, here, would you like to be a hero for today? That's how amazing this case is, so easy that it's a great case to receive. Two, because why is that? We discussed this deeply under Himanshu. When we do laser with minus, you're correcting the center, right? Now, if you looked at your OCT, which you don't need, a slit lamp can show you this. The scar is limited to the LASIK flap area. You see the depth all around. So my backup in my mind, which I never want to use and never have to use, is I would have just removed the LASIK flap and thrown it into the garbage, taken a donor cornea of the same thickness, put it without sutures and wait for 3 months. Good, we didn't have to go there. This case, in my talking and what I've said to you since morning, I do not believe in topo-guided stuff. Your topography will automatically improve if you do refractive treatment. You see, topography doesn't correlate to vision. If I give you topography, Aishwarya, can you tell me what's the patient's vision? Cannot. But if I give you refraction, you can guess the vision. And refraction is what takes to vision. As you've seen in all my cases, the scar may remain, doesn't matter. Topography as a welcome side effect gets better. But don't chase topography, chase vision. So I loved it. It has to improve. In fact, this patient would have come to 2020 had you done a surface refractive treatment. And your epithelium is what helps you in these cases. The backup, as Dr. Himanshu had rightly said, would be a lamellar surgery, but here you'd make it very elegant. You just peel off the LASIK flap, throw it into the garbage, put a donor of whatever 120 microns, no stitches, leave it with a BCL, and then it'll heal over 3 months. Come back and do laser, bring to 2027. Excellent case, but those are my thoughts.
Thank you, sir.
Right.
I absolutely agree with Dr. Gulani. The interesting part is we had an opportunity to look at the OCT also, which showed the anterior surface very regular, and which, as he said, with the myopia and regular anterior surface, that's a juicy thing right in front of you. Go ahead and do a refractive PRK treatment. And if the refractive error is high, well, I'm more happy, which should take care of this thing. Now, when we deal with, say, instead of this case, if you had a partial loss of flap, irregular flap with a partial loss, a crater on one side and a mountain on another side, doing just a regular refractive treatment would not have helped you. And that time, as he said, that you have to regularize the surface of the cornea more rather than just trying to take care of the refractive error there, because that refractive error would be highly irregular. And even though you get some refraction, it may not be very accurate. So here, if you have an opportunity to look at the nice regular anterior surface and the scar, which is very anterior, well, with myopia, and I would certainly go with him what he said, that a simple treatment of PRK can actually do the trick. Having said that, there are many different ways of handling a case. I really don't think I would call anything right and wrong. There are different ways of handling the case, and you did a good job to handle that.
Yeah, thanks, Dr. Himanshu. For the want of time, we have just about 30 minutes to go. Can we have quick presentations by all the faculty? Dr. Ramurthy, you can start off.
Yeah. I'm going to be presenting two cases. One is a refractive surgery in non-ophthalmic eye. Basically, this is a 31-year-old patient who had a refraction of +9 diopters in one eye with correcting to 6/9 and the other eye +14 going up to 6/24. Extremely unhappy because of the quality of vision and the kind of spectacles he had to wear. He was now not tolerant to contact lenses also. And this was basically his topography, and more importantly, to look at his AC depth. Because of his short AC depth, ICL was not possible. So if it was a highly myopic eye, then I would definitely stay away from doing a clear lens extraction. Mind you, he's a 30-year-old patient, but these are situations that I would go ahead and do a clear lens. But as you can see, there are various different formula. Most often today, I believe in Barrett Universal, but they are giving extremely variable measurements. So what I did was to go ahead and bilaterally do a cataract surgery. Obviously, it's a non-ophthalmic eye, so all the precautions that you would normally observe were taken into consideration. And 1 week apart, I did both the eyes. And then the result was we had a 6 plus 0.75 and a +6 diopter residual. Of course, the amblyopia was still existent. The simple calculation was for every diopter of hyperopia, you place 1.5 diopters. As was already alluded to, there's a sulcoflex lens which is going in a couple of weeks after the primary surgery. There's nothing special about this surgery and any one of us can do it. What I find is apart from the refractive surgery on the cornea, I'm more and more resorting these sulcoflex lenses, especially for when the cornea is not adequate and when a significant hyperopia needs to be handled. And might as well go to the end of the surgery, which is fairly simple. And then the patient ended up with an uncorrected visual acuity of 6/24, which was the potential as far as this eye is concerned. As I mentioned, this is more the concept that I'm interested in. And of course, the patient was pseudophakic, so had to have near vision glasses. But ultimately, what Dr. Gulani was all the time talking about, significant cosmetic improvement in the sense that he just had to go in for a presbyopic glasses, which was much more acceptable to him. If I can quickly go on to my next presentation, I'm in a few slides.
Yeah, I think we are planning to finish it in 1 or 2 minutes so that we can cover everybody.
Iatrogenic keratoconus. This lady had actually undergone LASIK procedure 6 years back in 2006. I handled this patient way back in 2012, and she came with blurring of vision in the left eye of 2 years duration. And what I found was the right eye, you can see there was some amount of myopic astigmatism, and more importantly, significant amount of myopic astigmatism in the left eye. Very unhappy with the quality of vision. This is the right eye topography. You can see onset of early keratoconus, but that was the better eye. What you see over here is the left eye, where you can see that iatrogenic keratoconus is well established, and she had a significant myopic astigmatism, and the best corrected visual acuity was 6/18. Today, if I had to do it, I would go ahead and do a intax plus a cross-linking. But at that point of time, we are just beginning our experience with the cross-linking and with intax also. So initially, we did the cross-linking to arrest the progression of keratoconus. She was still left behind with a significant amount of astigmatism. And you can see it was just 1.5 diopters with minus 14 diopters. And so went ahead with the implantation of intact segments. And I just move this forward. This is just the intact segment going in, and as was mentioned, this creates a barrier and significantly regularizes the cornea. You can again see the circle becoming more regular in the center. And what you see is that more amount of astigmatism is becoming manifest, but our best corrected visual acuity is improving on to 6/9 and a significant myopic astigmatism. We cross-link the right eye. This is the post intact segment implantation. You can see the topography over here. And year after this, now I might not have waited for that long. We went ahead and implanted a toric ICL. And she regained 6/9 visual acuity with this subsequent to best corrected visual acuity subsequent to this implantation. Basically, the patient got into trouble because of laser vision correction. And this is the picture 1 month after the implantation of the lens. And this is what you saw, iatrogenic keratoconus in the right eye, in the left eye, and came with a best corrected visual acuity of 6/18. Finally, we could end up with a minus 1.5 diopters of astigmatism. Obviously, it was a difficult case. We had to do a 3-stage surgery. Initially, cross-link the cornea, then place the intacts to regularize the cornea, then deal with the refractive error, implanting a toric ICL.
Yeah, fascinating surgeries, Dr. Amurthy. We also had I had series of presentations in nanophthalmos. Then I'll just summarize them. We also have done a lot of nanophthalmos surgeries. The eyes are very small, 16, 17 millimeters in length. What we did was we calculated the various types of biometry formulae. What to make it short, Barrett Universal 2 worked well, and Hoffa Cube worked well. Everything else is junk. It doesn't work in high hypermetropic patients. These two have worked well, and we could manufacture locally in Bangalore a lens which has got powers of 55, 56, 60, and 62 single-piece lenses, and we implanted them in one go, and our results have been fabulous. The largest surprise we had was around 1.5. So they were all extremely happy with this kind of lens. Dr. Gulani, would you like to comment on the second surgery? Or how do you manage nanophthalmos in your setup?
Nanophthalmos is simple. Just look at it like you said, take your precautions, no big deal. Dr. Ramamurthy, excellent presentation. I want to repeat one more thing again. Everything he did was correct. There is no options. That was the way to proceed. So I'm going to push this sentence a lot. You don't give options. The patient, when she came with ectasia, only one thing I would do different is I would have done the intact first, cross-link later, because I first want to make sure I've got the right shape. Cross-linking is permanizing it. Then I would have gone with ICL the way he did. He's perfect there. First case also was handled very well. So to me, again, I mentioned, it's not about giving options. That's the only way to have gone for those cases. It has to result in success. Excellent job.
I think if I may make a comment in the sense that, I agree with you, Dr. Arun, in the sense that today I handled this case in 2012, and that was just our beginning phase with the Intax. Today, if I had to do it, I would actually do a Intax plus CXL in one go. I was more comfortable with CXL, so I strengthened the cornea. Then I regularized the cornea. And of course, maybe the way you say it, we could have handled it. Ravindra, regarding your comment about nanophthalmos, I know that there are Indian companies which are able to make extremely high-powered lenses also. But my major challenge is good calculation. So retrospectively, when I saw in this particular case, SRKT, though I also go with a Barrett Universal 2 most often, SRKT gave me the most accurate power because it gave me 49 diopters, while Barrett gave me 56 diopters. If I put in a 56 diopter lens, I think I would have ended up with a significant amount of residual emetropia. Putting in a primary lens, then over that you just do a simple refraction. That gives you an exact idea of the power of the lens to be implanted secondarily, and just you slip in the second lens. And even this is small eyes, there's enough space for implanting two lenses. So I do a two-stage surgery.
Dr. SRKT, did you plan for emetropia or did you plan for residual hyperopia?
No, because I showed you 4 formulae. All 4 formulae gave me completely different values. So my basic idea was that, but in the first eye it was plus 40 diopters and it worked well. Second I did a plus 40 diopter and I knew there'll be emetropia. I'd primed the patient also for that, but I could get an exact refractive error which I could handle with a secondary implant.
Yeah, but our experience is a little different. Anyway, the final output is a comparison of what you got with Barrett 2 and the residual power that we had at the end of it. And the closest, if you do not want to go by Barrett 2, the closest was half a cube. Now, later, I found out that in all hyperopes, half a cube works better than anything else. I think we will work on it. Next is Dr. Pallavi Joshi. Can you present your post-PKP challenges?
Yes, sir. Is my screen seen, sir?
Yes, it's very well.
Okay, so now coming to a little different this is a case of 38-year-old female who came to my OPD who was post PKP 12 years back, and probably it was keratoconus, no other details. She is not from our country and she had but a history of progressive diminution of vision since past 5 years. Her uncorrected visual acuity in the right eye was counting fingers, whereas for the left eye, whereas the right eye was within normal limit. This is the picture of her eye when she came. Her right eye refraction was -4 with -2.5 cylinder and 6.6. But the grafted eye had this as her refraction, -18 with -6 cylinder. This is the picture of her oculizer, which showed a steep cornea with adequate thickness of the cornea. And this is her Bellin embryos. This is the opticon surface, which shows around approximately 6 dioptric refractive astigmatism. And this is her, specular. A specular of her left eye, post 12 years of PK. She has 1212. Now, the challenge with this patient was she wanted a 6.6 vision or a vision without wearing either glass or contact lens. Her expectation was at the left eye, she wanted that she didn't want to even try these clearer lenses. And she insisted on regrafting this eye, even though she had anatomically good graft. So this was my challenge because she was 12 years post PK, had good endothelium, and she had quite a good cornea. So I wanted, sir, your opinion with respect to such a case. What should be the one which we should be going ahead with her as an option to give her vision to near 6.6 without giving contact lens or emetropia? Just to tell what I did then when she was not for this was something different. I don't know how much it is approved, but this is something, what I did was graft remodeling. I went ahead and just refined her own cornea, went to 90% depth, used a refine, and actually resutured her cornea. This is how I did because it basically looked like a proud graft. I know suturing is something probably not something everybody would think about, but considering the limitations the patient had, that is what I did with this lady, to at least make her uncorrected vision or to bring down that extreme amount of, irregular astigmatism she had. So the same measurement went with we took the Pachymat and resutured her cornea. That is what I did with this lady, though I know I but want the opinion from all the expertise here with respect to what it would be. This is her post-op photo, 4 weeks, and this is 6 weeks. Now, this is how she is, -7 with -4. At least that cylinder of -18 is come down. And I know probably with the suture removal, something can be managed. So I want to know, in her case, if she's not ready for a refractive surgery, not affordable, or if there were other limitations like not ready for other extreme developed variants of managing this case, how to go about in patients post PK. Because the challenge is we have a graft host junction, which is not very strong, and still it requires something to make her see better. So this is just a case I had. I thought I will just share and take your opinion for the same. Thank you.
You can exit the share screen, doctor.
Yes, sir.
Exit.
So
Yeah. Did you consider doing the suturing only of the flat axis instead of cutting the entire all around? You could have just did segmental arc-like incision and suture them and controlled by keratoscope or something like that. Dr. Arun, how do you comment on this?
I would like to congratulate her. She really brought in what I fight for, artistry. She did not accept defeat. She did not accept defeat. She brought in her artistry and was minimalistic, what Dr. Himanshu rightly said, minimalistic artistry. Didn't go savage, didn't go destroying everything the previous surgeon did, except the previous surgeon did a nice job. Always accept that and then move forward. Now, what I would have done in this case, number one concept that I'm going to literally yell at everybody, which I repeatedly get from all over the world, especially from all of you, is what lens do you use when the patient asks for this lens in premium surgery? So while I blast you for that later, I'm going to say the same comment here. The patient cannot tell you what to do. You are the doctor. The patient cannot tell you what to do. You are the doctor. You look at it and go, this is what I see is going on. This is what I'm going to plan to do for you. I'm not giving you options, Mrs. Smith. I did not come with a mobile van to your house. You came to my office for a reason. So that's first attitude, because you're proud of your integrity and ability, but you're making it very clear. You don't succumb to what someone's saying, because that's the biggest reason of problems that I see patients flying to me for. Oh, my surgeon did this. Well, you cannot tell the surgeon. So point one, I loved it. You listened to her, but you went minimalistic because you also left your further gates open to do other things later. Dr. Ravinder very nicely explained to you, it could have been done segmental, yes, but I love the approach. Two, what I would have done here is, given that, if I remember, you said it came to 636 vision, which was excellent given where she was. I would have done a contact lens over refraction, and she would have surely come to 624 given the cornea. If that's the case, I would now attack. One is, yes, I would have done exactly what I've done, modify her transplant and bring her down. Now, where she is brilliant for you. You already came to Iceland, now take her to Paris. Do a laser surgery on this. So you will decrease her keratometry, cornea is thick, and remember, the more myopic the treatment, the more regular your cornea. Keep your zone small. If you had 7 millimeters of your corneal transplant, don't listen to this nonsense about zone being bigger and night vision. It's not the case. Industry hype. Go to 6.5 millimeters, stay there, do a surface treatment. This patient will be blown away with close to 630. What do you call it, 630? 20/30 vision? That's what she will reach if you do it that way now. You brought her to a perfect result. I love the fact that you went artistic.
Thank you, sir.
Okay, can we go to the next case, Dr. Deepthi?
Yes, Dr. Aditi, you could start your screen share. In the meanwhile, a lot of questions coming up from the audience. So in between, I would try to take a few. But Aditi, you can finish your case.
Yeah. Am I audible now?
Yes.
Yeah. Okay. So good evening. It's a great to be a part of this myth-busting webinar. Fine. So this was a 27-year-old male who underwent femto LASIK 22 days back. He came with the complaints of blurred vision in both the eyes, along with halos for the last 1 week with progressive worsening. Now, as per him, he clearly gave a history that he was absolutely all right for 10 to 12 days post-LASIK, and only after that he started developing this hazy vision. Currently, he was on a moxifloxacin loteprednol combination 4 times a day. The visual acuity in the right eye was around improving with pinhole to 6/9, and the left eye was 6/12 parts. The IOP by applanation was 25 in the right eye and 31 in the left eye. The central corneal thickness is around 480 and 510. So if we apply that logic, then the corrected pressures were almost up to 32 and 34. The pre-op refractive error was around minus 6.75 diopters. Now on slit lamp examination, this appearance was like a classical DLK with a whitish granular infiltration confined to the interface and a little of flap interface haze. The AC was quiet. Important to remember here, I'll just try to repeat that the patient actually started developing symptoms on day 10 post-LASIK. So this did look like a classical DLK, but the presentation was a little later. But nevertheless, we first wanted to take care of the inflammation. Did not stop steroids. We in fact planned to step it up along with the IOP lowering drugs. So put him on a tablet acetazolamide along with the timolol brimonidine combination and used a more potent topical dexamethasone 8 to 10 times a day. So the next day, the IOP did come down to 13, marginal improvement in vision by probably a few letters. We thought we were on the right track. We were happy. We decided to continue the treatment. However, after 2 days, we again saw some deterioration of vision and the IOP started rising again. We did an ASOCT and dived in for a literature search to understand what we were dealing with. And the ASOCT showed the presence of some interface fluid, which appeared like a tiny fluid cleft, and this was much more prominent in the left eye. So when we did a literature review, we actually came to an understanding that we were dealing with something called as a PISK or a PISK, which is a pressure-induced interlamellar stromal keratitis, also called as interface fluid syndrome. But there aren't many reports that have documented this condition. So we went for a change of plan. We decided to stop the steroids and just continue the IOP lowering medications. The vision improved to 6/9 in both the eyes. We were very relieved. We thought that we had nailed it right. We scheduled a review after 3 days. But he came back to us after 5 days to further confuse the condition. His vision now had drastically dropped. It was actually even worse from where we had actually started. Uncorrected visual acuity now was only 5/60, improving to just 6/24. The applanation pressures were 12/18, but at this point of time, I would just like to mention a thing. When we did the non-contact tonometer and the applanation tonometer, every time wide fluctuations, sometimes we would have a very high number, sometimes a very low number. We didn't have a tono pen or something to be used. The fundus was within normal limits. So we were in a big dilemma now as to what next. What were we missing? Was there some associated endothelial dysfunction or something else? Because this time when he came to us, he did mention that the vision was worse on waking up in the mornings and probably gradually a little better as the day progressed. So probably would like to hear from the panelists, from Dr. Arun, what are we missing here and what else we could have done?
Doctor, the PISK is a known condition. We have seen it almost a decade ago. Mm-hmm. The one thing that is erroneous here is you're checking with any kind of tonometry is fallacious. You should depend more upon your digital pressure rather than the instrument pressure. And the pressure can be, actual pressure inside can be 40, but then your machine can be recording 15. So the awareness of the condition is much more important. And you completely stop steroids. Dotoprednol is known to cause very high intraocular pressure. From that point, almost 1.5 decades ago, we are using only fluorometholone postoperatively, which we had no issues. So I think your digital pressure should not be considered as a clinical evaluation of the actual intraocular pressure. The first thing one should do is stop all steroids. You can put on non-steroid anti-inflammatories and, of course, the glaucoma treatment. So give value to the digital pressure rather than instrumental pressure.
Okay, so that's the point, well taken. But why did this condition, you think, went so bad again? Because we had stopped all the steroids and it was almost 5 days. He was on the path of improvement. And then suddenly this drastic deterioration, in spite of not putting him on steroids and giving all the IOP lowering drugs.
Because of shortage of time, you can complete the case. You can present the what happened later.
So that's it. Actually, this is where I end because this is where we didn't know what next and what should we really be doing at this stage because the vision had further deteriorated.
So I would request you to stop the screen share and Dr. Himanshu would discuss further. And Dr. J.K. Reddy, could you load your presentation? Yes, sir, Dr. Himanshu.
So this is very interesting, Aditi. I mean, it's not about cases, the premise Ravindra said, it's very well known. All of us have gone through such kind of, in fact, one such case, I was following up Dr. Somshila's case as a follow-up, and I thought it's bilateral DLK, and I increased the steroid and ended up with really high IOP, skeleton my cupboard. But the thing is, whenever there is very significantly increased IOP, there would be endothelial dysfunction. But what happens is when the IOP is raised, your cornea still remains compact and cornea does not show that stromal edema. As soon as you bring down the IOP, your endothelial dysfunction part will show up and your cornea will show swelling, and which will alter your refraction as well as everything. Now, if you had done a previously good job, and I always say that there are 6 causes of refractive error post LASIK surgery, and one of them is undeliberate or deliberate undercorrection. If it was not a case, well, I would just wait and watch. It's going to take its time. The younger patient endothelium will recover and you will come back to the regular vision. I don't think I would be worried about that.
Great. So I welcome Dr. J.K. Reddy, sir, to present your case, please. Great. That was a great case, Aditi, and great tips, Dr. Himanshu.
Good evening. I'm audible?
Yes.
Yes, coming to the case, my case. This is a 20 years old female patient on spectacles. The spectacle power is +8, +3 in one eye, +6.5, +2.5 in other eye. And this is a dilatation. And of course, remaining all, she wants a correction, unaided vision. And of course, topographies are all normal. Only issue here we saw is the anterior chamber depth is low. This is a 2.6, 2.6. So I have no option of phakic IOL. So what we planned in this case is a smile lenticule of a spherical spinal lenticule with a hyperopic refraction, of course, the LASIK under the flap, not in the pocket. And what we did is this is a very simple surgery. It's nothing, as Dr. GULANI is always telling, it's a very simple surgery. Any ophthalmologist can do it. Only thing is I didn't have a smile machine with me, so I borrowed it from my friend who is doing regularly smile. So we kept the lenticule there and ironed it out. It looks really bad on the table, but I know these corneas will clear over a period of time with my past experience as a corneal surgeon for the past 20, 30 years. So I ironed it out very well and centered very well and put the flap back and put on a contact lens and left it for some time. We left it for more time, 3 to 4 days instead of generally one day we remove it. And this is the post-operative in both the eyes. This is the refractive value. The right eye, somehow I landed with +0.25, +0.5 refraction, and left eye almost in plano. So this is the post-operative after 1 year. This is 2015 we did it, now 2020. The last time patient I saw is 3 years back. I would like to know the panelists, is there any other method you have in your mind to carry on patients like this? That's my
So,
Dr. GULANI.
So doctor, again, excellent job. Fantastic direction. No options. That's the correct direction. Wonderful job. You would have planned a lensectomy if at all. That's the only other option in this case, because remember one thing, and I think you already know, hyperopic treatment quality is less than myopic. The more hyperopic you make them, the less the quality becomes. But coming in these kind of cases where they may be nearly amblyopic to some extent because of that amount of hyperopia, this is a tremendous outcome in these cases. So I think applauded, excellent job, great job.
Yes.
Can I make a comment?
Please.
That was great, Dr. J.K. Reddy. So I welcome Dr. Himanshu to present his cases here now.
Hi, good evening. And, interestingly, because I saw what Dr. GULANI was talking about in the attitude part, and last moment I changed these cases. I said, I wrote to Dipti that, let me just change the cases which we were discussing earlier. Let me go with something different, what probably he would have liked.
So all this is planned in the last 5-10 minutes, probably.
So I'm starting with a priest who had undergone PKP surgery And I think JK knows this guy. The previous PKP surgery done in United States of America in left eye since 1996. And the right eye PKP with cataract done and then PRK done, but still didn't have the great vision. And the left eye, which was done earlier, long back, had very, very poor vision. That's what he said, that he never had great vision in that eye. The vision in the left eye was 20/100 and very, very blurred. And again, this is quantity of vision. The quality of vision was certainly bad. And the reason was the topographic astigmatism, very high astigmatism on the cornea, which is like 16.6 diopter on the corneal plane. Now, to me, this is probably the juiciest apple in front of me because very regular astigmatism, clear graph, which is functioning well for this many years. Rather than treating anything which is distorting this graph, what I have to do is, if this cornea remains like this, I might as well use this thing as my weapon and take care of this thing. So if you can see the quality of vision, total aberrometry shows very poor quality of vision. And what I did, well, I did a custom toric lens. We put a lens power, which is the cylindrical power, which was 20 diopter cylindrical power, and that time it was probably highest in my hand. And I was possibly a little worried that will it work or not. The spherical power was 18 and cylindrical power was 20. And I love to do this thing on first day when I like to open the patch so that I can get the first reaction. Before I check the vision, I mean, this person started checking his own vision and said, like, you know what, your newly operated eye is much better, much brighter, and this thing. And I was, okay, you know what, the vision, whatever is there, I'm happy with the surgery because patient is certainly very happy. And patient was really thrilled that for this many years, for more than 20 years, where the eye was not used, now he's able to see really great with that eye. And on in terms of looking at the vision, I know he just went on and on. Looking at the vision, the graph was fine. And again, all these graphs have very low endothelial count. Never get scared of these low endothelial count. It's just number. So most of the time they are in 400, it's 300. It doesn't matter. You still are fine. Graph is compact. You do a good job, and you would be actually fine. Post-operatively, the uncorrected vision was 20/40. And the best corrected vision with the refraction was 20/20. Patient was extremely thin. The eye, which was possibly not useful, has now start working. The corneal density, I mean, the endothelial density was same as pre-op, and patient did wonderfully well. So I learned from this thing that, you know what, you should challenge your boundary. Next case came was pellucid margin degeneration. Now remember, these pellucid cases have very high astigmatism, and this guy had against the rule astigmatism, which was very high. And this time again, with my previous experience, I was sure that I can touch these eyes. And now the astigmatism was 22.5 diopter. Remember, cylindrical power of 22.5 diopter, not the spherical power. A small change. We've been taught that 10 degree, 5 degree difference, and you will lose everything, 10 degree difference. All these are myth, what we learn in the literature. And again, went ahead with the surgery. This guy was a villager and was possibly somebody who had not used this eye for very, very long time. Again, pellucid margin degeneration, it's not an acute case. It's been there for a very, very long time. I opened the patch and asked him to see the vision. Again, this is more for the dramatic purpose. You surely can do these topical surgeries, but just to take this video, again, I'm not trying to justify anything, but it actually gives that thrill to patient as well as to the surgeon, that patient starts seeing something which is really clear on day one immediately when you open the patch. Now the vision improved to 20/20 parts, and patient was extremely happy and said that he never was so happy and never had seen anything so clearly in his life. In fact, he got emotional, started crying. He said, "Can you wait for 5 minutes?" Went out, bought a bouquet and gave it to me. What brings the important point out here, that never limit yourself with the numbers. Post-operatively, the excess was very stable and patient did wonderfully well. In the lieu of lack of time, I don't think I will go ahead with the other case presentation, and I would stop here.
Thanks, Dr. Himamshu. It's great that we have these manufacturers in India. I don't know, Dr. Arun Gulani, what is the highest cylindrical power that you have available in America? Now, just few days ago, I implanted a lens of plus 14 cylindrical power in an eye who had an eccentric, who had a high amount of astigmatism. And fortunately, this lens, we could make it out of hydrophobic material. So all these lenses are hydrophilic, but the hydrophobic material, they could manufacture a power of, plus 14. So what do you do in such a case in America?
Again, there are always ways around it. I think now after Dr. Himanshu's talk, you don't need me anymore, so I'll leave. But was fantastic at every level. I liked everything. Do not make excuses for seeing the patient happy. That is your pride. It's the only way to justify success. I loved it. You went without worrying about the topography. You said there is no limits. I loved all of that. Super. I'm thrilled with that presentation. There are no limits. And to add to that, Dr. Ravindra, that you have a company that can actually make these lenses. I love that camaraderie. So just this presentation made my day. It has everything that I always talk about. And the patient reaction, like I keep saying, if you're driving in the right direction with the correct GPS, you will reach the destination. It's guaranteed. So super job, Himanshu. Wonderful.
Dr. Arun, we have crossed the time. Can we continue for another half an hour and finish all the cases quickly? We will present. I think I know you. It's tough for you, but then if you can stay for another half an hour, we'll try to complete all the cases and get your opinion quickly. Another half an hour. Yeah, go ahead. Dr. Arun, can I have a nest from you?
Yes, yes, yes.
Please. Who is presenting the next one?
I'll be doing.
Yeah, please.
Dr. Deepti here.
Yeah.
So let me just run my video.
I think in 2 minutes, each of you can present so that we'll convey the gist of the case. Go ahead, please.
Yes.
You have to run the video. Yeah.
Male referred from Andhra Pradesh for corneal transplant. So this was a 60-year-old male referred from Andhra Pradesh for corneal transplantation. The only significant history he gave was acute red eye, probably 10 years back, which was mostly suggestive of a corneal infection. So thereafter, the eye started whitening and he gradually lost his vision. So I'll directly proceed to the surgical management. So during the surgery, we were actually amazed to see the stroma was very clear underneath, and this was actually just a superficial scar. So we could dissect the entire scar out. It was not very tough. It easily came out. That means it's probably just an epithelial thickening or a hypertrophic epithelium. And the stroma was crystal clear and pristine post-surgery, and we didn't have to do any transplantation or anterior transplantation in this patient. Now, another case, again referred for probable corneal transplantation. Similar to the previous case, but the scarring was not that significant. We could see a few areas of clear stroma. And again, proceeding to the surgery. Similar to the previous case, very easily we could peel off the entire corneal scar. A good cleavage pain could be achieved. So here again we see a very nice, pristine, clear cornea underneath. The limbus looks very healthy and the conjunctiva looks very healthy. Only thing this patient has is a subluxated lens. So we are just waiting for the surface to heal so that we can go for a secondary IOL calculation with a good measurement of IOL power. So we do see such cases basically wherever there is a limbal cell deficiency, you see a huge conjunctivalization or pannus. But these cases were a little unique because the conjunctiva was totally fine. So they were just probably something like a keloidal tendency, something like that on the skin. These are extreme thick hypertrophic epitheliums. So what we learn here, again, a careful clinical examination is a must. Even if you see little pockets or if you feel on high illumination slits that the stroma is a little clear, it's always better to do an OCT. OCT, this is the OCT of the second patient, certainly gives off a very good idea. So you see beautifully the hypertrophic epithelium and the very clear stroma. So any of such cases, it is advisable to do an OCT, and they do very well just by a superficial keratectomy.
Thanks, doctor. How do you
So
come
this is
across
a 60-year-old male referred from Andhra.
We go to the next presentation. Dr. Namrata is here. Dr. Pallavi Joshi.
Dr. Pallavi is done, so you can start your presentation now. Dr. Ravindra.
I'll come at the end if the time permits. Can the guest faculty present the next one? Dr. Vidya Shankar.
Dr. Vidya Shankar.
I'll come at the end if time permits. Dr. Vidya Shankar.
So in the meanwhile, I'll just take an audience question. Dr. Gulani, we have a question which asks, what do you mean by a measurable cornea?
When you're trying to do an intraocular surgery, whether it's phakic implant, cataracts, whatever, you must be able to measure the cornea because all the formulas depend on that, right? Techniques. Like I would put a toric lens in the eye, manipulate the astigmatism, make it astigmatism on the scar axis, and then do laser on that, depending on your algorithm. So very, very important. This is also called GPS, GULANI planning system, but think of driving. You have a GPS. So you always want the cornea measurable before you enter the eye. That's what I meant. And Dr. Deepti, your case is excellent. Again, that's what I teach of believe, meaning it's there. These cases, you should start with a blunt Tukes blade and start removing the epithelium, and you'll hit the scar, you lift it up. 100% of the cases, Bowman's beautiful underneath. And one thing I would have done if you were planning surgery, not your second case was more healthy. You could just do a small slit technique, put a limbal transplants on an amniotic graft, put a BCL on and leave it aside until you're planning surgery because you want it to be long-term after your surgery. That's the only difference for your case one, but well done.
Thank you. So I welcome Dr. Vidya Shankar. So you're not audible.
Dr. Vidya Shankar, you're not audible.
You'll have to unmute yourself.
Vidya Shankar, first remove your full screen and then unmute yourself and then go back to full screen.
So meanwhile, I'll ask Dr. Swaroop Reddy to keep ready. I have a question from Dr. Arush Kumar. This is for Dr. Himanshu. So he asks, sir, what K values do you use for such high irregular cylinders?
Well, frankly speaking, I won't worry too much about the K values. When you have regular corneas and if you are able to get a decent amount of central corneal measurement and like what Dr. Gulani said, measurable corneas, don't limit yourself that it's going to change a huge amount. I would be absolutely fine. If you have topography, I would love to take values from that. And I actually measure them manually myself rather than what topography gives me, or else even a regular reflection on the cornea through an autokeratometer also would be fine with me, provided your cornea is regular or measurable in the center.
Great.
Dr. Vidya Shankar Reddy?
No, still not audible actually.
We'll come back, doctor. Can you stop share screening?
Can we have Dr. Swaroop in the meanwhile?
Yes, ma'am. Yes.
Vidya Shankar, you try to unmute the microphone in the meantime.
Dr. Praveen, by the time we have this screen shared, we have another question about what formula for IOL power would you use for post-keratoplasty patients? So would you want to take that?
Yeah, sure. There is no one formula for keratoplasty patients because the issue with keratoplasty is irregular keratometry. the formula probably will depend more on axial length. And I think that is what you should follow, what is recommended. From the point of view of keratometry, formulas really don't make a lot of difference.
And how long would you generally wait after a DALC or a corneal PKP is one other question for doing a IOL or a cataract surgery?
Minimum of 3 months after all suture removal for either an ICL or to do a PRK on the surface, or maybe to do a cataract surgery. 3 months after all sutures are out is what I would wait. If the refraction continues to change, then 6 months after sutures are out.
Great. Thank you so much. So Dr. Swaroop, could you start the screen share?
Yes, doctor.
Yes.
Okay, good evening, everybody. This is a 23-year-old patient presented with defective vision left eye since 1 month. And he had a history of blunt trauma 3 months ago. He had a posterior subcapsular cataract. On dilatation, there was a spherophakia and subluxated crystalline lens with a zonal deficiency between 12 to 4 o'clock hours. And there was no significant phacodonesis. And dilated fundus was normal. A diagnosis of spherophakia with subluxated traumatic cataract was done. And the planning for surgery was that we had 3 plans. One was just phacoaspiration with foldable IOL. If it was a problem, go for a CTR ring. And if that was a problem, go for a lensectomy with SF-IOL with our retinal surgeon. And,
okay, you can tell the results, doctor. Surgical video is not very important. What did you do and what did you get at?
We did phacoaspiration. We implanted a hydrophilic IOL into the bag. The jonules were strong enough to withhold the surgery. Okay. And the patient had good postoperative recovery and vision. So there was, we didn't have to use a CTR ring also.
Oh.
Actually, spherophakia, jonules should have been weak and it should have been bilateral, but the other eye was normal. So it was some rare condition.
Does it affect the biometry recordings, your spherophakia?
No. Our recordings were, we got a regular IOL power and he had a good, there was no residual power postoperative.
Okay. Can we go on to the next case because we have...
So I request Dr. Suresh
Pandey.
Yes, I'm sharing my screen. So good evening, everyone. First of all, I would like to congratulate Dr. Ravindra sir, and it's a pleasure to hear Dr. Arun Gulani, who shared a lot of important tips today. I'm going to present a case of a 57-year-old doctor who is radiologist and who was keen for cataract surgery and lens implantation with minimal dependence on glasses. And there was history of bilateral 16 cut RK done 25 years back. On examination, his best corrected visual acuity in the right eye was 624 with minus 4.5 diopter spherical and with minus 0.5 diopter cylindrical. And in the left eye, his vision was 6.9 and anterior segment examination was unremarkable except he has 16 cut RK scar and posterior segment was normal. And in such cases, Dr. Gulani rightly pointed out there are issues to give, to provide best vision, 20/20 vision, but we have to be careful because of issues such as IOL power supply. And in RK, phacoemulsification in RK can cause wound gap. It may require suturing. There can be issues of fluctuating vision. So proper workup is very important, especially IOL power calculation, and counseling and chair time is very important to explain all the possibilities to do the best job. And we did the IOL power calculation, and his K reading was difference in the K reading was less than 0.5 diopter, and we started the multifocal lens after explaining him all the details about the surgery. And this is the brief 1-minute surgical video clip which I want to share. As you can see here, This was case of 16 cut RK, and we tried to make side port incision at the between the RK cuts, and we used chondroitin sulfate based OVD, which is viscose to protect the endothelium. The main incision was carefully fashioned in between the two incisions, and hydrodissection was done, followed by phacoemulsification. And the technique showed by Dr. Gulani that you should not move your phaco tip, you just move the side port. And the we have implanted multifocal lens with 3.25 diopter aid, and the lens implantation was done successfully with excellent visual outcome. And in these cases, it's very important to calculate the lens power, and this case went very well with the visual results of 6/9 post-op unaided, and the post-op vision was 6/9 unaided, and with the refractive results of -0.25 diopter spherical with -0.25 diopter cylindrical vision. Thank you so much for your attention.
Thanks, Sudesh. You must be really courageous to put a multifocal lens in a cornea like this with the multiple. Dr. Gulani, can you give your comment as to how to manage this patient and your concept on premium? Everybody talks about premium IOL, premium cataract surgery. You already said you're against using the premium. It's the surgeon who has to be premium. We would like to hear from you. What is premium cataract surgery, and what kind of lenses do you put depending upon the various parameters like the corneal asphericity or a distorted cornea like this or a post-LASIK cornea? What is premium in your opinion?
So first,
Dr. Gulani, before you start, I would heartily welcome Dr. Namrata Sharma, who's been on one
I'm so sorry. I'm really sorry for joining late. Yeah. Yes. Sorry.
Yes. Dr. Gulani, please.
Yes. Hi, Namrata. How are you?
Hi, I'm good.
So, first of all, Suresh, congratulations. I love the concept. I love the bravado. I love that you followed every step. 16 years ago, I had started putting in multifocal lenses for RK cases, and that's the questions I got on every podium, and I would fire them down by showing my patients. No stupid graph, remember, patients on camera. Today, 16 years later, all these patients I had put in multifocal RK, all of them are surgeons,
Wait,
attorneys.
your internet is unstable. Please wait for a second.
Hello? Hello?
Yes, we can hear you.
I think you can continue.
Can you hear me? So
Yes.
I think I like this a lot. 16 years ago, as I said, we started doing multifocals in RK. And again, that's your confidence of doing RK first with monofocal. Then you go to multifocal. These patients do beautiful, but you must know which eyes to have it in. Even though your cornea was 16 cut, it's a great case to show how this 16 was so stable. I saw you enter the eye, the cuts were rock solid, meaning it wasn't a weak cornea. That's a great point to remember here. Plus, you followed these principles that I've written about many years ago, nearly 2 decades ago, of don't move your instruments in the eye, keep them stable because you want to come out without sutures, keep your surgery corneal, flip the lens. That's the other thing I do in RK a lot. I don't like to go in and manipulate. Flip it out no matter how big. It's a deep chamber, get rid of it, put your lens in. So great job, multifocal lenses do work, but you have to measure the cornea. It has to be stable. Number of cuts don't matter. I put it in a 20 cut patient too. He's a surgeon. Night vision is great. Also, another great gimmick. The 3 diopters of multifocality actually takes care of your fluctuation. Either they're seeing great distance and great near or great both. That's the only fluctuation they have. They'll love you for this. Again, very careful, caveat, you have to measure the eye, make sure the stable incisions. These 16 cuts were more stable than many 4-cut irregular cuts. So great job. Now, coming to the question of premium lenses, which I get a lot all the time. I just wrote an article I told you in Ophthalmology Times called Show Me the Patients. It is still the largest reason for referral of patients to me from all over the world, unhappy patients with premium lenses. Most usually, the surgeon has always done a great job surgically. Where it failed is they didn't understand the technology. I cannot understand how you can have conferences on what lens to use in which patient. Think about it for a minute. All of you know about cooking. I did a fun video for you during this COVID lockdown where I taught as cooking. How a lens is just an ingredient. You are the master chef. You orchestrate the lens as one of your ingredients to make a vision recipe. So among 30 different lens options, I don't give patients the option. And then one question I get a lot after my previous webinar, what if a patient is demanding a certain lens? So how many of you get that question, please? Everybody, lovely.
Yes.
So how do you react to that? It's very simple. It's very, very simple. Can I take anyone's example? Let's say you're a father, okay, Suresh? And
Yes.
let's say you have a son, let's say 16 years old. That's when they watch TV, they're taken in by the ads. He comes to you, hey dad, and your son has juvenile diabetes. Now your son comes saying, hey dad, I've seen this ad and this phenomenal candy, you know, this chocolate, there's a new kind of chocolate. It's got M&Ms on it. It's unbelievable. And I've saved money from my pocket money also. I absolutely have to have that chocolate. What's your answer, Suresh?
I will say that go ahead for that.
What's that?
You can go ahead and get it.
But I told you he's juvenile diabetic.
Yes.
What would you say? Hello?
Perhaps, that you can get it, but you have to just manage the diabetes, by insulin or by treatment. He can get with, sometimes when he really wants to eat it.
All right. So what I would do, I would say absolutely no. So you're doing one thing very important here. You're letting the patient know who's the boss. You're the doctor.
Yes.
No one can come to you saying, I want this. It's not vegetables. You are making a logical decision for life. It's going inside your eye. So make sure it's serious. So my first question to that boy would be, no, you're not getting it. That shows your authority. 2, give explanation. That shows your knowledge. You're reasonably explaining why you said no. You're not just a dictator or an egoistic surgeon. So explaining, listen, kid, I love you like crazy, but you have diabetes. If I give you chocolate, you will go and it'll impact your health poorly. Now, then you suggest to him what exactly you would give him. Now, if you look at this system that I just came up with, you did 3 things here. 1, you establish that you are the person who makes the decisions, which is why the patient comes to you, right? 2, your son will not hate you. He, in fact, will start admiring you that you actually said no because his health was more important. So the patient starts admiring you because they may have been to 3 other doctors before you. All of them said, yes, I will do it. Let me make you happy. And she looks at you and goes, this guy's a pretty smart guy. And you're giving reason. Mrs. Smith, because you have fixed dystrophy with high angle kappa and a shallow chamber, I'm not putting a multifocal lens because that'll cause halos for you. But there are 30 lens options. And given that you still have high astigmatism and your vision requirements at all places, given my measurements and your visual capacity of fusion, I will put a toric trifocal. Additionally, the patient may say, hey doc, and I want that special lens because my husband wants to give it to me as a gift for my anniversary. We can afford it. So you add to that. In fact, the lens I have explained to you costs 2,000 more. Now, business side of it, someone who's ready for 5,000 is surely ready for 50% more. But what is important to the patient is she understands you're the authority, you're not going to sell anything, and you're thinking in her best interest. Where will she bring the rest of her family, you think? What will she tell her husband when she goes home? You have to meet this doctor. He's rock solid. He doesn't bend. And oh my God, he knew about 30 lenses. I thought there was only one, the one they advertise on TV. And this is the guy I want. And by the way, Mr. Husband, I know you love me. You have prepared for 5,000. It's going to cost 7,000. But I'm telling you, this is the guy I want. That's it. No more discussion. So again, I come back to my point, no giving options. Of course, there is responsibility you have to perform, but that's the discussion in my office every day. No patient can say, I want this. You explain why you're selecting what you are. So that's one. Second is, I may have to go back to my presentation about premium. Premium is everything. How your office functions, how you function, how you give them time, how you make measurements, your track record. Remember, I call this a lot. Surgical acrobatics in the eye is entertaining. It's not performance. Every move you make in the eye must be artistic, taking you straight to perfect vision. That's today's webinar. You can go in the eye, put stitches and hang lenses and play with the vitreous. Pathetic if the patient is unhappy. Correct? So my approach to premium is, let me see if I can share my screen, is everything has to be premium. Your discussion has to be premium. Let me bring it up. Okay. Can you see now?
Yes.
Yes?
Yes.
So we went over a number of cases. Now I'm going to go quickly to what I believe is premium. This is clear system. I call it the 48 techniques every eye surgeon should know. 48 glasses according to somebody who's not a candidate. You must know how to mix cornea, cataract, laser vision techniques. Be a master. Not, I have a burger and a hot dog. What can I get you for lunch? Wrong. LASIK, smile, whatever. Wrong. 48 techniques. You don't give options. You look at the patient's optics, anatomy, physiology, visual potential, come up with one plan. That's all you're getting, Mr. Smith. That's the best plan. Are you with me?
Yes.
So we go straight from here to the 3T system. I always plan target, go to technique, and then technology. Technology is the least important. You are the master. Don't call your surgery robotic. By calling it robotic, you have decreased your importance, and now the whole town will compete on money. Have you seen that in your city? The patient will look for a certain robotic cataract surgery, not for Dr. Smith or Dr. Sue. Get it? They'll play with you now. I'm getting the same lens. Why are you better, doctor? I want better price. What they have to understand is the lens is an ingredient. You are the master chef that makes every recipe amazing. So technology everybody has. We go from here to techniques. This I already showed you. All these patients are seeing 20/20. No need for transplant. This is corneoplastic. Then the concept of how I think. These were the central scar cases I showed you. In cornea, on cornea. I'm going fast. Now here's a case I'll show you quickly again to go back to attitude. So here's a patient, if you see, with the scar in the center, 7 diopter astigmatism, traumatic central scar. What would you do? Again, see, I'm not showing you topography. It doesn't matter in these cases. What would you do? What's the first thing you think I'm going to do? For time. Refraction. Remember, so many videos. I don't care for the scar, even if it's bang in the center, I'm going to refract with my streak retina. Have all the technology on this planet, but that's my go-to to really know the answer. So when I refracted this patient, I refracted him with 7 diopter astigmatism down to 20/30. You don't want to do transplant, he's a bodybuilder. So what does he do? Next day, he's 20/20, and you can see here, he sends me this video next week. Can you see that?
Yes.
Can you please get addicted to these things? Every surgery of mine has my patients in it, the world's most demanding patients, the world's most litigious country, wanting to send me all this on their media. Important, that's what you live for. Again, 5.9 astigmatism, peel off the scar, Dr. Deepti. I always can peel off the scar, go in and do cataract in the future. Here's a patient with nystagmus, +8 hyperopia, +7 astigmatism, amblyopia, strabismus, all the stuff sent from South Africa. Doctors, nobody can touch her. Impossible. So we design an instrument to hold the eyeball. Here she is. Look at her with glasses. Just look at the error. And she's been left like this. Very beautiful, very wanting to do great things in life. Held it here. And now if you go here, see the patient, what she's doing next day. Get addicted to that place. Very important. She's stuck in the US right now because I couldn't do a second eye because of COVID lockdown. We'll plan it. Black Hawk pilot with scars. Patient with 22 diopter astigmatism, 12 diopters measurable on topography, a kickboxer. Herpes, 20/20. Any kind of RK, don't worry about the cuts. You can do it. This is again a patient I'm showing you just to show you even RK pieces, if they are dislodged on the cornea, you can put them together like a jigsaw puzzle, laser over it. Have confidence. These things work because epithelium is your most powerful refractive error. Well, need for time, I'll keep going. Rarely do I ever have to remove a patient lens. This is a physician sent to me from RK ectasia from Idaho, +7 hyperopic surprise with -12 astigmatism with ectasia. But exactly right, I start refracting and take them straight to vision. So this case, we talked about how we make them myopic and plan rather than think about surgery. Then scars, intact concept we talk about too. Let me take you back now to the premium question you had. And I want to show you exactly the patient experience should be. So all of you, when you operate, to me, any one of you, can you please describe what premium means to you? Anybody, please. Dr. Namrata.
So premium means premium technology, premium lens, and premium technique.
Very good. Excellent. So more important to me, what was missed here? Can you please tell me, all of you?
Surgeon, premium surgeon.
Results.
You are the premium.
Got it.
Surgeon is the premium.
You are premium.
You are the
Don't worry now if I'm late. You are premium. You are the master chef. Stop giving so much importance to an ingredient. How would you like it if you make food for your wife or your husband and they go, that food tastes great because of that expensive ingredient I bought? Won't you slap that person? Right? How does it sound? Tell me. Tell me that you have not seen this, because this is the second reason people fly to me. Patient coming to you and saying, for example, hey, I'm seeing great. Dr. Suresh did my surgery. I'm seeing great, but here's why I'm seeing great. I paid $4,000 for that lens technology. How do you feel? Pretty horrible, right? No one knows your name. I paid for that technology is why I'm seeing, because you push that in your ads. When they're not seeing and unhappy, what do they say, Dr. Suresh?
They say the surgery is at fault. You are not done.
Yeah, the surgery was not done properly.
Lovely. And they say even more. They say, despite the fact that I paid $4,000, that stupid doctor couldn't get it right.
Surgeon goofed up.
Yes. Why will you tolerate that? Tell me. You see how wrong the system is? Please stop calling the lenses premium. You are premium. You. What I'm going to show you here, I'm very late for my work, but what I'm going to show you here is the videos of how patients respond while you're treating them. And that's very important. You cannot say patient is happy and here's my graph and look at my topography. That's nonsense. Show me the patient in no pain. You see this now? Ready? Can you hear it?
Fantastic. You okay?
Oh, yeah.
Super.
I'm enjoying your light show.
I'm inside
Let me stop you here. This patient has had 6 surgeries, was sent to me from Abu Dhabi, keratoconus with failed intacts, PRK, PTK, cross-linking, you name it. I was doing his lens exchange surgery through that cornea. How is the patient's reaction? I repeat for you once more. All these patients are some of the most highly demanding in the world's most litigious country, and already undergone what I call post-surgical stress syndrome. Meaning they don't trust anybody, they're angry at their surgeon, they're already watching everything you do. But look at the reaction of the patients. That's premium. Look at the ambience in which you're operating. That's premium. Look at the way you are talking. That's premium. The lens is, of course, premium. An ingredient in your recipe. Are we clear up till now? Yeah? So, and I cannot understand this debate when people have like, what lens would you use? I'm like, there's no such thing. How do you choose a lens? So anybody, doctor here, how do you select your premium lens, Dr. JK?
Yeah, I select my lens depending upon what it suits his conditions or what's his profession, something like that, what he needs in his want. I have a lot of problem. I mean, things like you people ask for it. I want specific. I don't accept. I give only my lens of my choice. I said this is my choice. If he's very adamant, I say you go to somebody else. It doesn't matter.
Lovely. And have the patient ever left you when you said that?
No. Never. They bring more patients.
You got it. So this is the part of business. When I teach business of medicine, all the doctors are on one side and I'm on the other, and they still don't understand when I say this. You have yet to lose a patient when you're speaking high integrity. You're not selling. Doctors are constantly asking, doctors, how do you talk? What do you wear a suit? I'm like, I wear a suit because I'm a fashion designer. I love it. If my watch doesn't match, my belt doesn't match my shoes, I'm uncomfortable. You can wear shorts with polka dot socks. Whatever you're comfortable, your patient thinks you're a rock star. Don't forget this. Just try walking into a grocery store. Doesn't have to be good looking. Your patient will just jump and tell their family, that's my doctor. Isn't he amazing? Have you seen that reaction? Have you?
Yeah.
Yeah,
so every surgeon is a rock star to begin with. So my point is, you'll never lose a patient by being straight and honest, and you're being honest. How do I decide a lens, doctor? I look at the patient. I don't even care what they're saying. I want this and I want that. You can't have all that. This is not glasses that I'm going to put over here and you'll see. You have your anatomy. I have to do your surgery. Your brain has to adapt. I have many things going on, Mrs. Smith. Do you understand? Oh, I thought this is a surgery I can have on the weekend. I don't work on weekends, Mrs. Smith. You understand that? Can I have both eyes? I'm in a hurry. If you're in a hurry, I don't have time for you. Otherwise, I was going to spend 2 hours with you today. My surgery takes 4 minutes. I'll spend 40 minutes during surgery because that's my style. I love to sit down and have fun with my patients. Which patient will leave you when you say that? So the concept here is, look at the anatomy, physiology, optics, very important, optics. People don't understand lenses. The most patients who come to me, it's because the lens was sitting there. I call that half done. Take it to the end zone. It was sitting in midfield, hit it right off the boundary. And who looks like a hero now? Because the poor surgeon did such a hard job, the cataract. And you're going and correcting the astigmatism, making the lens look good. Everything looks great. Where do you think this patient's bringing her daughter for LASIK? To you, right? So what's your budget for marketing that you should keep?
Zero.
To market yourself.
They should market for you.
So that's my premium lens take, please. How you treat the patient, how you be a doctor, which you are, how you're already performing great surgery, and of course, delivering vision. You can't, as I say, you cannot pack up garbage. Has to be great results, safety. Another important thing that surgeons forget. I'll show you in surgery. You have to be a very delicate surgeon. You're operating on these patients topical, no matter how complex. You have to be in and out like a dance. You cannot be in and playing around, dance, and you're talking. They're listening, everything. That's premium experience. How are you doing, Mr. Smith? So tomorrow, are you planning to go to the beach? Excellent, I'm done. Make sure you're resting too, all right? Have a safe flight. I'll see you tomorrow morning. Experience for the patient. So as surgeons, I don't want people to go into more lenses. I want them to rise even more, artistry. That's my point. The premium to me is the whole system. It's not options that they're giving. Have you seen those options that doctors give? Platinum, gold, and garbage. What can you afford? Have you seen that? Anybody? Yes? Multifocal, toric, monofocal. Got it? Sounds like a waiter in a restaurant, right? You're a surgeon. You come inside and go, I'm picking this lens among 30. Do you know how many lenses are approved, by the way, in the world? Anybody? 82. So what's your excuse of having only 3? Again, you don't have to stock it. What I'm saying is you're picking. How I did my little cooking video for you all during this COVID. You look at the patient's anatomy, physiology, optics, visual, potential. Walk to your kitchen, pick the ingredient that you need for that recipe. And therefore, I keep repeating, there is no options. You can't say, I would have done this and I would have done that. No, everybody would have done this. That's the whole paradigm shift I'm trying to bring into ophthalmology, and cannot not show the patient during surgery. Cannot show me all these maneuvers. You know, that answer I give, a lot of people ask me the same question again and again. Dr. GULANI, what about the stitches in the lenses you take, secondary lenses and vitreous and all that? I told them, do you know the difference? If a firefighter jumps from the 3rd story of a building into a fire and saves somebody, he's a hero. But the guy on the trapeze in the circus is an entertainer. You're getting what I'm saying here? Perform. Just doing things and not having vision. I get this all the time. Patients have had topo-guided stuff. Topography looks great, patient's blind. The scar has been removed with PTK and patient has great refractive errors. That's failure. It's not success. Lens has been put in place secondary. The doctors are talking about different techniques. Patient has 6 diopter astigmatism from tilt. Failure. So what we have done today is amazingly taken it to artistry and outcome. I do have to leave. Anybody else? Anything else I can answer? Questions?
Should I share the last case? It is interesting. So maybe, yeah.
Go ahead, please. I'll do it.
Okay.
In the meantime, Dr. GULANI, we really liked your way of presentation. We have learned a lot today, especially to promote ourselves and not our technology. And that is something we are all, especially our president, Dr. Rashekar, who raised this question on a chat discussion. He always says, promote yourself and do not be a slave for the technology. And the second thing is...
let me modify that. Okay. Don't promote yourself. Let your patients do it.
Okay, good. The second thing is use of retinoscope by a physician, which is a forgotten art. And you insisted again and again. But I would like to tell my young juniors that retinoscope is not a forgotten art. That is a modern gadget over which you can see actually what kind of media, what kind of refraction he has. I think everybody should have a retinoscope next to them and do not hesitate to watch that. Yeah,
A
go ahead,
refractive,
doctor.
a refractive surgeon must know how to refract. Period.
I see a lot of surprises that we see postoperatively is not because of technology, it's because of the poor refraction that was done before the surgery.
You cannot tailor looking at the mirror.
Okay.
I explained all these concepts today, right?
Okay.
You cannot tailor looking at reflection in the mirror. That's like looking at topography and fixing the cornea. Absolutely incorrect. You have to fix the problem, which is refraction.
Okay. Dr. Patwardhan, can you go ahead?
Okay. It's very nice to listen to you, Dr. Gulani. Coming from the same institute, KEM, if you remember, from the same UG, I have done the same. So this is my small case in refractive. And the question is, what will you do? I have treated this case 4 years back. So 23-year-old male with history of trauma 12 years back. And patient underwent surgery for right eye traumatic cataract. And he was implanted 3-piece hydrophobic IOL. His uncorrected visual acuity in right eye was finger counting 1 meter, and the left eye was 6/6 unaided. While the best corrected visual acuity was 6/18, and his refractive error was -7 and -2 cylinder. And this was how the anterior segment looked like. The pupil was superiorly decentered, and iris was covering the center of the eye. And iris appeared adherent to the superior incision, and yak capsulotomy was already done. And I could also see a kind of fibrous band, which was probably vitreous, which was going into the incision. And this boy, for last 10 years, he had not used any glasses, but now he wanted the surgery because he wanted a job for which he has to have 6/9 or better vision. The corneal, this thing was normal, so corneal procedure was possible. But of course, the pupil was decentered. So what will you do in such case?
What did you do, doctor?
Yeah, so I will just show what I have done. Anyone would like to comment on this?
Dr. Saurabh, continue with your discussion because we have fag and we have crossed it almost by 1 hour.
Yeah, can you see the video now?
No, it's not shared.
I will share again, just one moment. Okay.
No, it's not playing, doctor.
Yeah, I will play. So in this case, I decided because the pupil was decentered, obviously because of the post-trauma and the iris adherence. And so I had to bring the pupil back to the center. Of course, that should be the first step. The one option was piggyback IOL. So correcting the, placing the IOL in the sulcus. But intraoperatively, I found that, of course, there was a vitreous strand which was going there. It was fibrous. And I didn't want to do it in one stage. So initially, I did the pupilloplasty and removed that vitreous strand as well. On table, I realized that despite releasing that iris from the incision, because this was almost 8 years old, so there was probably some atrophic iris, shrunken iris, it was not coming to the center. So I have already marked the visual axis, the center. So I decided to cut the inferior part of the iris so that the pupil kind of centers. On table, I decided that I will not do any suturing of the iris because I didn't know how the pupil will do later. So this was the post-operative photo. And because the pupil tracking was difficult with LASIK, I decided to go ahead with SMILE here. You can see the pupil is little large, but the patient was fixing properly, so I could do the SMILE properly. And post-op, he got really good vision. I had already explained to the patient that I may need to do pupilloplasty again if the pupil remains dilated, which I was expecting. So this was the end of the surgery, and patient got 6/6 parts vision, which was what I had not even imagined because his best corrector was 6/18 before. But maybe because the pupil was now centered, he got a better visual acuity. And 6 months later, he came back after 6 months later, and pupil was reacting to light. I asked him whether he would like me to do pupilloplasty to just make that pupil smaller, but he had no symptoms whatsoever for glare or anything. So I left it like that. Patient was extremely happy and got the job also. So that was the case from my side.
Dr. Arun, would you like to comment on this?
Again, I like it. Excellent, Saurabh. I love the attitude part more than surgery, like I've said before. Keep getting surprised. But biggest thing about all the cases I show you all every day I do is I want to make sure most that they have limitations. There is nobody with limitations. Just go for it. 30 diopter astigmatism, attack. You don't tell 11 feet tall guy you will not stitch his suit. It'll come out half inch short or long, but you're still a master tailor. Are you getting my point?
Yeah.
I loved it. Now, few things different. Whether you did smile, I would have done a surface procedure because that would get the irregularity of the cornea too. But I like it. Either way you went, got the whole refractive error too. You'll see this a lot. I have hundreds of cases where patients were flown to me for bad pupil along with issues, and I don't correct the pupil. In fact, again, I like to play. Remember, my surgery is very simple. I don't operate for surgery. I operate to fool the brain. Can you listen to that for a minute? Can you let it go in? Your eyes are just my excuse, Mr. Smith, to get to your brain. Does that make sense, what I just said?
Yeah.
It's my excuse to get to your brain because I cannot manipulate it from any other way. So surgery is my only way to get there. That's how I think. But what I see constantly of videos that are sent to me is the surgery, the complete absorption of the surgeon in cooking. They're not worried about the food looking gorgeous, smelling phenomenal, and tasting great on the table. Are you with me?
Yeah.
They're so lost into their vessel, they're showing that they're cooking, robotic. They're putting the different ingredient, premium, and then they mess up because no one eats the food at the end, lawsuit. So that's the mindset I want for everybody here. So I love the fact that you went all the way. I want you to be more surprised with all this because all these things work. Many, many patients are flown to me with these pupil issues. I don't take the pupil. You know what I do? Fun things. And again, I say this a lot. Whenever you think from the patient's point of view. A lot of surgeons waste a lot of energy in what to say. How will I sell? Is this correct? How will she feel? A lot of energy wasted. Think like a parent to a child. You don't have filters, right? When you tell a child, don't jump, you mean it. Don't jump or you'll die, right? So it's simple. You tell the patient, this is what I want. You don't have to think so much and let them buy, don't sell. Are we clear about that statement?
Yeah.
So all these pupil cases, I optically play with them because you're right. Nobody knows the right size. So someone sent me from New York, Dr. Gandhi, this patient had traumatic cataract with pupil. Can you please use your skills and get a 20/20 and the pupil and all? I'm like, I'll make the plan. Now, when you plan, you see, oh, this is the non-dominant eye. And the pupil is about 6 millimeters dilated, but circular. Look at the right eye always. That's about 5. So she's not really a small pupil. She looks pretty okay, except in bright light, which no one looks at. All right. And it's a non-dominant eye. So I take the traumatic sublux cataract, remove her cataract, make her vision -1 monovision. Take immediately, which the surgeon didn't even send her for, the dominant eye, make her 20/15. Now I have given her monovision, slightly blurred in the distance. Her pupil just doesn't matter. So you see, again, we went to the cases I showed you, optics or anatomy. Optics or anatomy. Anybody can go in and put the pupil. My question to you, how do you know what size? What if she comes back and goes, Doc, I'm still seeing it. Now what? You'll go for 2 millimeters back inside the eye? Or will you expand it and cut it, make the patient look like a cat? So everything has a role. Everything has a role. But the indication cannot be an option. You look at it and just think optics the way I just shared today, not surgery. What should I do here? I know what the New York guy said. He wants me to do this. He wants help. I know, I understand. He's a colleague. But can I take advantage of her disadvantage? How's that statement? Can I take advantage of the disadvantage? Give me a fully traumatic case. I want 20/20. How you saw me playing with optics. Surgery happens. This decides what you do. This happens. Surgeons have it backwards. They're constantly in the eye. And they're like, let's drive the car. Let's see where we land today. That's wrong. You plan your destination, plan your GPS, then step on the gas. You will always land in the right place. Correct? So excellent case.
In this case, any other way to handle it?
Superb handling. I would not have even gone after the vitreous strand because it was fibrotic and it was old. And the fact that you were getting 636 tells me that the pupil wasn't that much an issue. I would have opened it up inferiorly a little bit because the lid will come down anyways. Again, I like to avoid excessive surgery. Remember, the patient never comes to you saying, I have a scar. They say, I want to see. So your language has to be exactly the language of their ask, vision.
Okay,
Excellent.
one I think about the surface ablation, you said that none of your patient gets pain. So what is the secret behind that? Because
Tell me the secret of people who are getting pain. I don't get it. Many fellows have come to me. Some of them, I had them spend 6 months interviewing patients. I feel it's the way it's done. A lot of nonsense of using alcohols and brushes and things that are traumatic to the cornea. I'm a very minimalistic surgeon. When I enter the eye for cataract, 3.5 minutes, I'm out. Again, remember, please, it's not for speed. I give 40 minutes per patient because I walk them in, I have fun with them, they want to hug me, whatever. Surgery, the time is only to know that you're being very artistic and deliberate. You cannot be in the eye going this way and that way. Elegant everywhere. A PKP should take you 22 minutes stitching with both hands. Should never need to do a PKP ever in your life. So learn all the skills that all these amazing doctors are teaching in these webinars. But be the master chef. That's my request to all of you. Stop thinking surgery. Be a master chef. Plan, perform, and get blown away by all these patients that people say cannot be done. There is no such thing. All right?
Thank you.
Okay. Doctor, we have 3 more presentations. I'll request them to finish it in 2 minutes each. Kindly bear with us. Dr. Lucy, are you ready with your presentation? After that, Dr. Namrata will go. Then after that, the last one is Deepthi. We'll have to close because we are running really late.
My screen is visible?
Yes. Both audio and video are great.
So my case is that of a 30-year-old male from Bahrain who had presented to us with refractive error of minus 3.5 cylinder in the right eye and left eye with minus 3.5 spear and minus 5 cylinder. He was a known case of keratoconus with contact lens intolerance. With the protocol that we follow in our hospital, it's a published protocol. So he fell under the risk of moderate to high risk of progression in view of his age, eye rubbing, atopic eye disease, and frequent change of glasses. So as per our protocol in the right eye, because the corneal thickness was close to 450 microns, we went ahead with topo-guided PRK and cross-linking. And in the left eye, where the corneal thickness was less than 450 microns, we underwent with intracorneal ring segments along with cross-linking. After 2 years, the same patient presented to us for visual rehabilitation. He didn't want to wear glasses. So we thought about what options are available. We made sure that the keratoconus is stable and there was no progression noted. So amongst the options, he was still contact lens intolerant. So we decided to go ahead with ICL in these cases. Now, what were the challenges that we faced? The inability to get proper refraction in keratoconic eyes is known, more so in cases with intracorneal ring segment, and so was it for us. We had different refraction in his left eye, the eye with the intracorneal ring segment, from our 2 senior optometrists. So the first question was to go ahead with which refraction. Next, each time the keratometry was repeated, it showed data gaps. So the reliability of keratometry and which one to use for ICL calculation was again a big question. White to white was not measured automated ways. This is a representative image, but in this case, we found it extremely difficult to measure white to white in automated way. So we went ahead, did some literature search, and we found that there were multiple papers of toric ICL in keratoconus, including one from our center, but there was only one report of ICL in cases of keratoconus with intracorneal ring segment. And in their methodology also, they did not address our challenges. So what we decided in this case was first to decide on which refraction to go ahead. In keratometry, the refraction in the 4-map refractive as well as on the EKR did not go beyond 5 to 6 diopters. So we decided to go ahead with our second optometrist refraction, which was minus 6 diopters. Now to choose the keratometry, again, it was a question, but we decided to go ahead with equivalent K reading with 4.5 millimeter zone because that was the mesopic size of the pupil and chose that for our ICL calculation. Now, to measure white to white, we did it using digital caliper, but it showed many intra as well as inter-observer variability. So we confirmed it by measuring it manually on the shine flux image and used the same. Postoperatively, our patient did well in the right eye, which was the better eye and was 6.6 parts unaided. The left eye, which was the worst eye with the ring segment, showed 6.18 parts with a good wall. So we were jumping with joy that, okay, this was probably the desired outcome, but our patient did not reciprocate the same feelings. he said that he's not happy. He's still not able to use both his eyes and he's confused with the images, two separate images. So we thought what more could be done. On taking a brief history and evaluating him orthoptically, we found that he had past history of amblyopia in the left eye, for which he had taken treatment for some time and stopped. So we gave him adult amblyopia therapy by inverse occlusion and explained him neuroadaptation. But we just didn't explain him. We gave him a couple of training exercises to fasten the process of neuroadaptation. After doing 15 days of continuous training at our center, he was happy, slightly better than what he was in the initial post-operative period. And we sent him back with a couple of home-based exercises. So this is how we went ahead with this case. We would really appreciate if some other ideas or any other experiences that you would like to share for this case.
Yeah, we don't see Dr. Gulani there. It's Dr. Lucy. It's a fantastic presentation. I would have done the refraction myself. I wouldn't have trusted either the optometrist. So this is something which you'll have to be confident in doing it. And there is a machine which can do the refraction optometry manually. So that's apart from the electronic autorefractor, there is a refractor which is available, and that gives much better results than autorefractometer, keratometer. Dr. Gulani, did you listen to the talk?
Yes, I did.
The case.
And this is a great example of GPS. Planning direction, new direction. First of all, please, again, I appreciate you guys have learned this way, but again, the webinars here are fun because of your experience. You're like great surgeons. But the thought process is missing. Stop putting keratoconus in a box. Here's what I say, think outside the cone. Did you hear that? Think outside the cone. Think of keratoconus as a refractive case. And 2020 you have to get, otherwise you have failed. Now you see how you would have changed your management. Once you've gone down a wrong road, doctor, now you're going in dead ends and turning around all. Have you ever been lost somewhere while driving? Right? You see how that feeling you get? You're going on the gas, but you're like, oh my God, when can I turn? That's what happened here. GPS is off track. Surgery was excellent. So I would approach every cone. Every cone is refractive to me. There are 28 techniques. Think outside the cone. So when I would have gone with the Intacs, I would have first planned my vision surgery. Remember, Intacs falls under my classification of inaccurate stabilizing surgery. Intacs cannot predict vision. Yes? No?
Yes.
But laser can. So laser was accurate. You did a great job on the other eye because it was predictable, measurable. So you attacked and went all the way. Never crosslink unless you have your result. Crosslink has only one reason to be used: after you fix the cornea. I'll show you one slide and I will shake your foundation about cross-linking, because my next article coming out, I've called it Linking Without Thinking, the third reason for iatrogenic blindness in the world. Okay, from there to your left eye planning. The planning was completely directionally wrong because you didn't think about tomorrow. You came with some classification, some protocol. It said go Intacs, not laser. I hate that way of approaching a patient. Will you have a burrito? Will you have a hamburger or a masala dosa? You look like a waiter when you do that. You have to plan for the patient. Mr. Smith, for your cone, this is the plan. Step 1, step 2. This step you'll take after you're stable. Do you understand, Mr. Smith? Yes, doctor, I got it. That's how I would have gone. So when you went in the wrong turn, now you were having trouble because you were hitting dead ends. Measurements were off. Why were measurements off? Inaccurate cornea with inaccurate Intacs. Your measurements have to be off. Are you with me?
Yeah.
Right? So plan forward. Again, there are articles I'll put up on my YouTube, but that's my biggest catch here. It's not about how you had a trouble of measuring. My problem is the car went in the wrong direction. All right? Let's go. Next one, please.
Dr. Namrata, would you like to present yours? We're not seeing the screen. Yeah.
Yes.
So this is about an 11-year-old male child who presented with diminution of vision and pain in the right eye for 2 days, and we'd done I saw a smaller collagen cross-linking with PCL 2 days back, and the patient came with hand movements close to face with PR accurate, lid edema present and papillae present on the upper palpebral conjunctiva with congestion of the bulbar conjunctiva and watery discharge. So this is how the patient looked like on post-op day 2 of collagen cross-linking, and there were infiltrates which were present, and the corneal thickness did not seem to increase much. But this was the pre-CXL investigations of parameters for both the eyes. So that is to say that patient had keratoconus, which is more in the left eye as compared to the right eye. And after doing this, we did a slit lamp evaluation. The infiltrate was 4 to 4.5 millimeters, and corneal scrapes were done. Because of the microbial keratitis, the culture sensitivity showed staph, which was susceptible to tobramycin, chloramphenicol, tetracycline, genta, vancomycin, and cefoxitin. Now, the patient was receiving post-operatively moxifloxacin, and it was resistant to it. So obviously, that could have been one of the reasons why the patient had infection. Now, this is the day 6 post-op, and then day 9 post-op, it increased. But notice also that at day 9, you could see that there were some dark areas here which looked like clefts. So this was a finding which we did not expect. And when we looked at the anterior segment OCT, the corneal thickness was markedly increased, almost more than 1100 microns. And it looked more like an acute hydrops picture. So for us, this was a surprise. And I wanted to present this case for 2 reasons. One, because of the fact that for microbial keratitis, we do advocate collagen cross-linking, that too for bacterial, and here it has caused because of this. And 2, also because immediately on post-op day 2, you have acute corneal hydrops. So probably and seemingly the microbial keratitis has either incited the acute hydrops, and then because it was acute hydrops, we did start, another dilemma was whether to start topical steroids or not to start topical steroids. But because the culture report was in hand and we gave antibiotics for 48 hours round the clock, so we did start topical steroids, and then this did resolve, and you can see the clefts which are resolving, the large cleft which is resolving over a period of time. This is at day 14, then this is at day 16, and then day 18, the microbial, the infection did resolve over a period of time, and the corneal thickness did come back to normal. But it is quite thinned out, and we'll now have to see how we are possibly going to rehabilitate this eye. So it is for this reason that I wanted to just present this case, and this is open for discussion. So how do you think, Dr. Gulani is there, we can rehabilitate this case now if there is a scar which is because of microbial keratitis combined with the fact that posterior part of the cornea is also affected because the desmets ruptured and there was acute hydrops there. So if you have to visually rehabilitate this patient, what would be your next course of action apart from, of course, doing a keratoplasty, which we may have to eventually?
Right. And this is a child, you said 11 years old, as I remember, correct? So it's a child, you don't want to enter the eye, but there was a hydrops or a posterior desmet stare for sure, correct? Yeah. So again, it's a child, you don't want to do a PK as much as you can avoid for many reasons. You also said he had come to you from somewhere, so there's travel involved, am I right?
Yeah, from Rajasthan. So follow-ups, travel. But the fact is that apart from doing keratoplasty for visually rehabilitating this child, I mean, I can't think of any other, procedure which can be done.
Correct. So if you look at the 5S system, again, the personal things we discuss are also important. That's why we are so unique as doctors, right? We're thinking about his travel. This is a young child, maybe cannot afford medications long-term. You do not want to keep a weakness in his eyeball. I would still go lamellar in this case, deep lamellar, and not go too deep, too close to the desmes. And that surgery with its anti-running 8-bite suture and leave him alone like that for many reasons. One, again, there is travel, there is support in the eye, you haven't opened the eye, infection rate is down, and you've given him some rehabilitation, send him back for 6 months. Comes back, you will see. We all know, my whole concept of corneoplastic and lasers and removing scars is based on the fact that when a scar becomes more posterior in the cornea, it is less impactful on vision. So by doing that, and also we know it's not active eye drops because you said the cornea has been stable for this long. So whatever it is, it's in the back of the cornea. As long as we leave some stroma above the desmos, I would do a lamellar in this case, keep this patient fine that way, send him out, let him come back in 6 months. Obviously someone's following him somewhere, see how he does. And we might be surprised, we now have in my 5S system, a nicely rehabilitated cornea. Now we go and see what do we do visually for him and help him out. That'd be my take on it.
Thank you. I thought as much. I think DALC is going to be the next step and then see how it goes.
A little above that.
DALCs, you have, surprises. You have astigmatism. Then again, that needs to be tackled later, I guess.
Absolutely. Absolutely. Perfect. Excellent.
Everything needs to end. Dr. Gulani, I'm so grateful to you. This was supposed to be a 90-minute program, but we have doubled. We have crossed all barriers. We have still about 6 or 7 very good cases to present, but I think we'll have to end this with Dr. Deepti. If you're sharing the video of tattooing, you could quickly, 1 minute. And as she's explaining, I would like to thank Dr. Gulani for his kindest gesture of coming on air to benefit everybody here. Dr. Deepti, over. Dr. Deepti. Yeah, this is the music you can unmute. We get a lot of patients who have bad corneas. There's no visual possible. They only have a white cornea and optic nerve is dead. So the cosmesis is extremely important. We have developed a technique of our own, wherein we do a lamellar package in the corneal stroma, remove the epithelium, and instead of the classical tattooing on the top, we create a lamellar package and put soot inside that. As you can see, this can function in many ways. Patients will have enormous cosmetic benefit, and even if there is an iridotomy, instead of going and suturing the iris, we can do a sectoral application of soot in the stroma. This soot remains inside the eye for a real long time. We've been doing it for 15-20 years now, and there is no reduction in the darkness of the cornea that we get. So that's the soot on the bowl. That is taken on a blunt corneal keratoconus and stuffed inside the stroma. Soot being totally inert, it does not cause any inflammation. We have not seen any corneal melting. We have not seen inflammation in the eye, and it heals extremely well. And with single one entry, you can cover the entire cornea without. Though it's black in color, the other eye could be dark brown, but from a distance you will not be able to make out a difference between the hospital. It will be very, very comfortable. Even if there is a stromal corneal opacity, you can go and do such suitable. Thanks, Dr. Deepti. I'm indebted to Karnataka Ophthalmic Society, the members and managing committee, the Bangalore Ophthalmic Society, and every one of the faculty who have spent a lot of time with us. And I'll request the Dr. Arun Samprati and Dr. Elan and Dr. Krishna Kumar, if he's here, to propose vote of thanks.
Hello, sir. On behalf of the Karnataka Ophthalmic Society and the Bangalore Ophthalmic Society, I sincerely thank Dr. Gulani. I think he is one of the most sought after speaker now. And in spite of his busy schedule, he has given us double the time he has promised. So I sincerely thank him. And I thank Johnson & Johnson, and in particular, Mr. Vamshi and Jaswinder, who has helped us a lot in this organizing this program. I thank all the speakers and the panelists. And most importantly, I would like to thank Dr. Ravindra and Dr. Deepti, who has put in so much of effort in making this grand success. Thank you, one and all.
My special thanks to Arun, Gulani, and my apologies to your staff. They must be trying to pull you out of the webinar, but then you were so kind, and we learned a lot today. Lot of not only the cornea, not only the anterior segment, lot of management aspects, how our relation should be there with the patients you taught us, and we look forward to join us again. Thank you.
Thank you so much for having me again. You guys are amazing. Keep up your fantastic work. Just a great dialogue. Love you all. Anything you need, just let me know. All right?
Thank you. Thank you.
Bye-bye.
Thank you. Thank you so much.
Thanks to everybody.
Thank you.
Bye-bye.
For having me again. You guys are amazing. Keep up your fantastic work. Just a great dialogue. Love you all. Anything you need, just let me know. All right?
Thank you. Thank you.
Bye-bye.
Thank you. Thank you so much.
Thanks to everybody.
Thank you.
Bye-bye.